Thank you very much, Sam. Appreciate it. Thank you so much for your technical assistance as usual. Welcome to everybody who is joining for this wonderful conference in nephrology. Really excited to hear from all our speakers. And we have a really good lineup for you here. I want to thank Dr. Saiba for helping us put this together. And we know that some of you are still filling out those pre-tests. We're going to give you a little bit more time. I'm going to hand it over to our President, Donald Gordon, for a few opening remarks. And I also want to thank AstraZeneca, who is our sole and main sponsor for the entire session today, for their sponsorship of this conference. Over to you, Donald.
Thank you, Peter. I like your shirt, man. Right. Okay, good morning, colleagues, esteemed presenters, sponsors, members of the Secretariat and technical team who rely on so much for the flawless production and execution of the day's webinar. It's my pleasure to welcome you once more to another of the association's webinar. The focus of today's webinar is on the long-term effects of the non-communicable diseases on the kidneys and how to manage and mitigate the damages done to the kidneys by these diseases. Chronic disease, as we know, extracts a very high toll on the health of our population, with its tremendous cost and the lowering of the quality of life for those who are so unfortunate to suffer from this terrible condition. As physicians and healthcare providers, we encounter and struggle to deal with an ever-increasing number of patients with chronic kidney disease. And so it behooves us to equip ourselves with the necessary knowledge and information to treat our patients confidently and successfully. It is our hope that the information carried in today's webinar and the knowledge imparted will equip us as healthcare providers to both prevent and manage the scourge of chronic kidney diseases. In closing, I'd like to recognize the role of the main sponsors, AstraZeneca, who came forward with a very generous support to assist in the underwriting cost of today's webinar. We in the association look forward to the continuation of this mutually and beneficial support. And we invite you all to enjoy today's webinar and take as much as you can get from it, because the knowledge imparted is very relevant. And thank you all, and back over to Dr. Peter Swaby. Thank you very much.
Thank you, Donald. Much appreciated. At this time, we're going to have Dr. Arlene Henry Dawkins open us out with a word of prayer.
Good morning, everyone.
Morning.
Let us pray in reverence as we usher in the presence of Almighty God, Jesus Christ, and the Holy Spirit. Our loving Father in heaven, we thank you for your great love and blessings which you have bestowed on us. Thank you for the opportunity again to share time and knowledge in this virtual meeting hosted by the Association of General Practitioners. We pray, Lord, that you send your Holy Spirit to our midst to expertly guide all the proceedings, lead and grant wisdom to all the presenters as they impart their knowledge on the relevant topic of nephrology today. Inspire our thoughts, discussions, and ideas as we receive information being imparted with clarity and expertise by the presenters. May we capably apply the knowledge gained with the best of our abilities to the daily management of the persons in our care. May your abundant blessings rest upon the moderators, the sponsors of the conference, the audiovisual and administrative personnel, to ensure the flawless delivery of the proceedings and a resounding success of this conference. We ask all of these through your Son, our Lord Jesus Christ, in the unity of the Holy Spirit. Amen.
Amen. Thank you so much, Arlene, for that prayer, and to to get us started here and ask God's blessing on our conference. At this time, we are going to be hearing from Dr. Kenyel Chrysostom, who's a nephrologist, and he'll be speaking about the classification, staging, and management of chronic kidney disease and the calculation of the EGFR. Now, just some brief bio data on Kenyel Chrysostom. He hails from the twin island of Trinidad and Tobago. So you're gonna hear a little Trini accent in there. And he's a past student of both UWI St. Augustine and UWI Mona campus in Jamaica. After completing a Bachelor of Science degree in chemistry in St. Augustine, he went to study medicine at UWI Mona, where he graduated with a bachelor's of, MBBS in 2013. He completed his postgraduate studies in internal medicine in 2019, graduating with a DM. His area of interest within internal medicine is the study of kidney disease, and subsequently he went on to complete his clinical fellowship in nephrology at the University Hospital of the West Indies, Mona, where he currently practices as well as in private practice. He's a member of the Caribbean Institute of Nephrology, where he served as a presenter in consecutive years at their annual conference, and he holds professional memberships in the American Society of Nephrology and the European Renal Association. He's also published and has an abstract of his research on chronic kidney disease prevalence on the island of Montserrat in the European Dialysis and Transplant Association Journal, and has special interest in chronic kidney disease and slowing its progression. His extracurricular interests include the piano and steel pan, exercise and fitness, as well as socializing and enjoying light-hearted moments with family and friends. In short, he's a true Trini at heart, but he's here with us in Jamaica. Welcome, Dr. Chrysostom. I'm going to turn it over to you now.
Okay, good morning, everyone. The topic I'll be presenting today, as you can see on the screen, is classification and staging, as well as management of chronic kidney disease and the calculation of estimated GFR. So I'm not sure what the spectrum in terms of age group is like in the audience, but these two gentlemen, I'm not sure how many of you know them. This is the great Desmond Haynes and Gordon Greenidge. They were one of the most prolific opening pairs in West Indies cricket, when West Indies cricket was quote unquote great, not so great anymore. But for the cricket fans out there, that was just to show you that, you know, being the first presenter, I hope to have a good initial start to support the middle order and the heavy hitters that are to come. So our presentation outline, we're just going to go into a little bit of background, classification of chronic kidney disease, definition and staging, and subsequently to the calculation of EGFR, and just a brief overview on management. So chronic kidney disease has become an ever-increasing problem. With the aging of the population, CKD has become one of the most common non-communicable diseases in the world, as well as a leading cause of mortality. And these non-communicable diseases are, in and of themselves, a leading cause of morbidity and mortality in the Caribbean. Now, the prevalence of CKD in Jamaica is estimated to be roughly 10 to 12% of the population. However, it has been challenging over the years to quantify due to the paucity of data in terms of over the entire country. Hypertension is the leading cause of chronic kidney disease in Jamaica, compared with diabetic nephropathy, which is the leading cause worldwide. So let's just get a little back to the basics, the key functions of the kidney as we know: filtration, salt, water, and acid-base balance, and hormone secretion. So essentially the kidney is the the purposes of the kidney are for clearance of metabolic waste substances as well as reabsorption of needed solutes. It regulates the sodium and potassium homeostasis, as well as acidotic and alkalotic states. And we know that the kidneys are responsible for secreting hormones that stimulate red blood cell production, regulate blood pressure, and they are responsible for calcium and phosphate regulation as well. Now, the parameters for classifying chronic kidney disease, it's mainly 3 parameters that are documented. One is the estimated glomerular filtrate rate, 2 is albuminuria, and the third one, which is not really used, is the cause of CKD. It is used infrequently in research, partly because there isn't a lot of data when it pertains to that parameter. And as you would see in future slides, the heat map doesn't really classify CKD in terms of the cause. It mainly highlights the EGFR and the presence of albuminuria or proteinuria as we know it. Importantly, if you rely on any one parameter, meaning the EGFR or albuminuria, it can be misleading because, for example, waiting on the decline in estimated GFR is misleading given that some conditions actually predispose patients to hyperfiltration, which would in fact yield a normal GFR in the presence of ongoing kidney damage. And one example of that is in the case of the early stages of diabetic nephropathy. So let's go through each of them one by one. Now, estimated glomerular filtrate rate, or GFR, it's the product of the average filtration rate of each nephron, the filtering unit of the kidneys, multiplied by the number of nephrons in both kidneys. Now, normal GFR is approximately 130 mils per minute per body surface area for men and 120 for women. So it's approximately about 8% higher in young men than in women. And of course, it declines with age. So the variation in GFR is considerable among individuals according to their age, their gender, their body size, their physiological state. For example, pregnancy, it increases in pregnancy, for example. So to standardize for the glomerular filtrate rate and for differences in kidney size, the GFR is indexed for body surface area, computed from height and weight, and is expressed as the 1.73 meters squared. Now the average rate of decline, of course, it would vary from individual to individual, but generally it's 0.75 mils per minute per year after the age of 40. And the cutoff point for GFR used to define CKD is less than 60 mils per minute of body surface area. Now, this parameter has been rigorously examined, and a reduced GFR represents a higher risk state compared with normal levels for a variety of outcomes. So it is also at this reduced GFR, you begin to see the relationship with the prevalence of anemia in CKD, acidosis, hypophosphatemia, hyperparathyroidism, and those commonly associated conditions. Now, reductions in GFR can be due to a decline in either the nephron number or the single nephron GFR. So what happens is, as each parameter, whether the nephron number decreases or if the nephron number decreases, there's an increase in filtration of the single nephron GFR caused by increased glomerular capillary pressure or glomerular hypertrophy, which compensates for this decrease. So why is this important? The level of the GFR may not reflect the loss of nephrons because of this compensation, and as a result, there is usually substantial kidney damage before you see that reflected in the GFR, which is why CKD is such a delicate diagnosis in terms of, if you see the GFR fall slightly, you know that it is after all the compensatory mechanisms for kidney damage have been exhausted and the kidneys are unable to compensate further. Now, we just spoke on the glomerular filtrate rate. What about, what's the difference? Glomerular filtrate rate versus the estimated glomerular filtrate rate. So the classic method for measuring the glomerular filtrate rate was originally described by this guy called Dr. Homer Smith, and he used inulin, which remains the gold standard in terms of measuring the GFR. And this technique, it is ideal because the kidneys don't absorb, it passes straight through the body without any interaction from other solutes. And this method, however, it tends to be a bit cumbersome in terms of implementing it in clinical practice. So there are many alternative clearance methods and filtration markers used. So GFR cannot be directly measured in humans, so the true GFR remains an elusive concept, right? So these markers that we use, we have exogenous markers and endogenous ones. Now, the endogenous ones are commonly the urea and creatinine, or plasma proteins, which would be the cystatin C. Now, creatinine is derived from the metabolism of phosphocreatine in muscle, as well as from your diet, your meat intake, or if you're into bodybuilding and stuff, creatine supplements. Now, creatinine generation is proportional to muscle mass, which could be estimated from age and gender, as well as body size and even race. Now, the advantages of using creatinine to estimate the GFR is its ease of measurement, and it's fairly low cost in terms of the availability of assays. The disadvantages, however, would be things such as a variation in the production due to the dietary intake, changes in muscle mass, and creatinine is actually it is secreted from the proximal tubule. So the advantages, however, outweigh the disadvantages when we plug other parameters into the overall formulas that we use to calculate GFR. So creatinine is still a very useful substance to assess the glomerular filtrate rate. Now, urea, unfortunately, is not as good because the production rate of urea, it's not stable. It also is variable with increases in protein diets or even tissue breakdown, in GI bleeding, muscle trauma, or even when administering steroids. So it's very variable, you know? So it's not an effective substance used to measure. Now, comparing creatinine to, let's say, a cystatin C. Cystatin C has a more stable rate of production and there's less variability, but cystatin C also has its disadvantages in that the levels of cystatin C are influenced by determinants such as if the person has thyroid disease, steroid use, their age, their ethnicity, their gender, whether they are obese or the extent of adipose tissue. So each one has its pros and cons. So overall, the most useful utility still remains creatinine for its availability, its low cost, and the ability to plug it easily into one of the formulas that we would see very shortly. Now, albuminuria, we have different methods of testing it. We have the common urine dipstick, we have the 24-hour urine collection, and we have the spot sample. Now, a lot of persons normally ask which method is the best, whether it be the 24-hour collection or the spot sample. Now, the spot sample it has been recommended by the guidelines as a useful means of assessing albuminuria, simply because the spot samples are standardized to the urine creatinine, and it is then normalized to the 24-hour excretion to account for any differences in the concentration over a 24-hour period. Now, usually the sample is taken first thing in the morning, that is the spot sample, and compared to the 24-hour collection. The 24-hour collection theoretically is more accurate in terms of estimating the albuminuria, but the process of collection is very tedious, and sometimes it's very subjective because patient compliance varies over the 24-hour period. They don't know when the 24-hour period starts versus where it ends. They may miss one or two samples. So it poses a substantial burden on the patient. So usually the albumin creatinine ratio, the spot sample is ideal in terms of getting the results, the relevant results to impact management. Higher albuminuria, I should mention, is independently associated with cardiovascular and all-cause mortality. So this is why this is also a useful parameter in the classification of CKD, because it has implications in terms of cardiovascular and all-cause mortality. So this one, the cause, it is, like I said before, it's not commonly used. If you notice the rubric here, we have the heat map that measures, well, the green zone, the yellow zone, which is high-risk patients, the orange and the red, where we have, well, low risk to high risk, I should say. And the cause of CKD, I mean, just for the sake of our edification, it is categorized based on whether the cause of CKD is due to systemic or intrinsic cause. And intrinsic kidney disease is based on where it is in the kidney. So it can be glomerular, tubulointerstitial, vascular, cystic, or congenital. And yeah, like I said, it's not really frequently used in the classification. Now, the definition of CKD, this is taken straight from the KDIGO guideline. You have to have either of the following present for greater than 3 months. That is a decrease GFR, which is less than 60. In addition, you have to have at least one marker of kidney damage. Commonly used is albuminuria. However, other markers include, urinary sediment abnormalities, abnormalities seen on histology, structural abnormalities seen, whether it be by a KUB ultrasound or on CT, or electrolyte abnormalities due to tubular disorders. And it has to be persistent over a 3-month period. So one collection of the albumin creatinine ratio, one spot sample result is not going to be diagnostic. It has to be at least 2 positive samples, and those 2 samples must span over a 3-month period, in addition to the reduction in GFR. So this is how it is staged. So we have the green section, which is basically low risk. Those are patients that you may see a reduction in the GFR, but they have no markers of chronic kidney disease. So that would be the green section. So even in the presence of a decreased GFR, if they don't have markers of kidney disease, you can't really call them kidney disease, chronic kidney disease by definition, because we know that, you know, your GFR declines over time. And the yellow is persons that would be at increased risk of developing CKD. This is provided that they have no other markers present. The orange and the red, those are your high risk and your very high risk areas. And those persons, once you are diagnosed with at least a stage 3 go down, you tend to identify markers of CKD, and those would be your typical CKD patients. So what do you do in terms of the different stages? What's your plan of action? That's usually the question based on whatever stage you identify in your patient. So from stage 1 to 5, the recommendations differ. So at stage 1, which is fairly early, you diagnose and treat CKD, you treat the comorbid conditions, and you slow the progression of CKD and essentially reduce cardiovascular risk. That is just a very blanket statement saying whatever the underlying cause, you try to control that. You assess the amount of albuminuria since it's linked to your cardiovascular and all-cause mortality, and you try to reduce cardiovascular risk, which usually means assessing the extent of albuminuria and starting the patient on maybe an ACE inhibitor, preferably, or ARB, or something to reduce the proteinuria. For stage 2, we estimate progression. Stage 3, that is the stage when you usually see the incidence of the associated illnesses that come with CKD, meaning the hormonal disturbances. We evaluate and treat the complications. And a severely decreased, that is as it approaches stage 4, you prepare for either dialysis or kidney transplant, ideally. And I should mention that the preparation for dialysis does not start at stage 5. It really starts in stage 4, where patients are referred for fistula placement, or they're referred for evaluation by your nephrologist even before. But the decision to start dialysis should never be a rushed decision, or a decision that the patient has not been mentally prepared for, unless of course it is in the case of critical illness or acute kidney injury or acute on chronic kidney disease. So in terms of referral, this is essentially a recommendation based on the stage of chronic kidney disease, which would be the same heat map that was illustrated earlier. So you usually refer if you have severely increased albuminuria, right? So regardless of the GFR, once the patient has in excess of 300 milligrams per gram, so you do an albumin creatinine ratio, and the proteinuria is increased more than 300 milligrams per gram, that's an indication to refer, right? And basically, you discover that the patient has decreased eGFR below 60, and they have moderately increased proteinuria or severely increased proteinuria, you refer from very early. So from stage 3A with severely increased albuminuria, you refer that patient to the nephrologist. And definitely for stage 4 and 5, there's no question about it, you have to refer the patient to prepare for dialysis or transplantation. So how do we calculate the estimated GFR? Now, these are commonly utilized equations. They are readily available online, but we'll just go into them in a little bit of detail without getting too technical. The three that are most commonly seen, the Cockcroft-Gault, the MDRD, and the CKD-EPI. There's also another equation that combines the serum creatinine with cystatin C, and it is found to actually be more accurate than the CKD epi. So that formula is utilized in patients that, they have a decline in eGFR and no identifiable markers of kidney damage has been found, and we need to confirm whether they have CKD or not. So in cases where that confirmation is required, we can utilize that equation, but it's not really commonly utilized in our setting. So just a little bit on the Cockcroft-Gault and the MDRD. The Cockcroft-Gault is the oldest formula. It is approximately, it's like 40 years old to estimate the creatinine clearance. And it was developed in a population of Caucasian men. That's where the study was done. So it doesn't take into consideration sex, because we know that eGFR varies from male to female. It doesn't take into consideration race or body surface area. So it is barely used in clinical practice, very, very rarely used. And comparatively, the MDRD equation, which is a bit newer, it's definitely more accurate than the former equation. The problem with it is there is a high number of false positives. So although the MDRD has a high accuracy for individuals with CKD, because it was originally tested and studied in patients that already have CKD, CKD 3 and 4 to be exact, it underestimates the glomerular filtrate rate in healthy individuals. So this results in a high number of false positives when it comes to the diagnosis of CKD. So that leaves the CKD epi equation, which is the one that I feel we use most commonly. This one is the newest. It was developed in 2009. It had the largest database of people being studied, those with and without CKD, and also diabetics and persons with a history of organ transplantation. Now, this one is all-encompassing. The equation includes age, race, sex, and standardized creatinine. So it has similar variables that are put into the equation, because the MDRD also uses some of these, well, if not all of these variables. But the CKD epi, when it was studied, performed better in those with glomerular filtrate rate over 60 mils per minute of body surface area. Now, in addition, the CKD epi equation eliminates the high incidence of false positives seen from the previous equation. And it translates a decreased prevalence of CKD, and it's really more precise, right? And it's accurate across a wide range of patient characteristics. And we could use it in terms of clinically applying the eGFR. Now, the kidney failure risk equation, that's another available online resource. I do recommend that you implement it in your practice when assessing the risk of progression to dialysis or the risk of kidney failure. It is pretty useful. It uses the age, the sex, the GFR, and the albumin-creatinine ratio to predict the overall risk of the patient. So you could at least have an idea what percentage risk in 5 years' time is this patient going to be on dialysis? Should I be referring this patient from early given the high risk I've gotten? I would say it's a useful tool to implement. Now, moving over to the management, I know that this is going to be covered in great detail further on in our session. But the general aim with all management of CKD is to slow progression, regardless of the etiology, right? My colleagues that will follow me will all speak on these management principles for different conditions. But briefly, of paramount importance is blood pressure control and RAS blockade, right? So an ACE inhibitor, ARB, for any patient with proteinuria. Blood pressure control for all patients, right? And for diabetics especially, even if the diabetic patient is not deemed hypertensive, if they have proteinuria and they have a high cardiovascular risk, it is definitely recommended that you start an ACE inhibitor in that patient for its pleiotropic benefits, right? HbA1c control for diabetics as well, although I must stress that actually blood pressure control is more critical than HbA1c control in diabetics, and concurrent cardiovascular risk management. We minimize the risk of AKI because acute and chronic kidney disease or an acute event can rapidly lead to progression of chronic kidney disease. So in elderly patients, the pneumococcal vaccine, generally getting the COVID-19 vaccine. Vaccination in general, it is a tool to prevent acute illness and hospitalization. In addition, we avoid nephrotoxic agents. What does that mean? We avoid drugs that will directly cause damage, whether it be glomerular or tubular damage. That would be like your non-steroidal anti-inflammatory drugs. In addition, you also want to reduce or minimize contrast studies. Contrast-induced nephropathy, it is still a real thing in our side of the world, simply because of the type of contrast we use, which has a high osmolarity. In developed countries, there may be contrast that is water-soluble or isoosmolar. We generally use highly hyperosmolar contrast, so they tend to cause renal vasoconstriction at the afferent arterioles, which lead to acute kidney damage. So we don't want to send our patients for studies that aren't critical in their management, or it won't impact their management, I should say. But more on this later down in the program. Lifestyle and dietary changes. We cannot stress this enough. Limit sodium intake, generally to 2 grams a day, or salt intake to less than 5 grams a day. Protein intake is usually adjusted based on the estimated GFR. So for the latter stages of CKD, meaning 4 and 5, you want to cut down the protein intake to just about 0.8 grams per kilogram per day. There's some more flexibility with the earlier stages where you could go up to 1 gram or 1.2 grams per kilogram per day. Regular exercise is always recommended for cardiovascular benefits, and that is moderate intensity exercise, meaning exercise where your heart rate goes up by at least 20% and you sweat. That's a good marker of it. At least 150 minutes a week. And of course, we monitor for the complications that are associated with a declining GFR. That would be defects in your calcium and phosphate metabolism, your anemia, and acidosis, which aim to correct same. So you usually monitor these patients. For stage 4 and 5, you monitor these patients roughly, well, we monitor them every 3 months. For stage 3, as long as it's stable disease, 3 to 6 months is okay. And that is stage 3B. Stage 3A and up, annual checkups would suffice once we are certain that the CKD is stable over time and the patient is on the right track. So that concludes my opening innings for this webinar, and these are my references. I thank you for listening.
Thank you very much. Thanks very much, Kenio. That was wonderful. Good explanation. Trying and made it very simple and understandable. Feel like I'm a lot more knowledgeable now. But we are going to open it up for some time of question and answer. So I'm going to ask Sam, if you would, to field those questions and just give them to us one at a time.
Will do that. So thank you very much, Dr. Chrysostom, for your presentation. Ladies and gentlemen, that was a wonderful presentation, very detailed, great information. Though I know you got a lot of information and perhaps it was delivered so wonderfully, I'm sure there are a couple of questions. So please, let us see it in the Q&A. Do you have any questions? Not a question, but a thank you from a Dr. Ruth Hannah. She says, thank you, I enjoyed the presentation. Thank you, Dr. Hannah.
Thank you.
Appreciate that. Anyone else with any questions?
Well, while we wait on some questions, I have a question with regards to sodium and protein. I assume that a dietitian is definitely the way to go. But
Absolutely.
can you give us any practical tips on how to estimate sodium intake and protein intake in terms of CKD?
Well, you have a number of tools available in terms of apps on your phone that can give you the amount of protein in a given serving size for a host of different things. They can give it based on the weight. For example, if it's like a meat, chicken, or fish, they can tell you for every 16 ounces of chicken, you consume how much ever grams of protein. That's one way. You could use it on the phone. The other way would be simply to go, when you go to the supermarket, you look at the nutrition facts, and it documents exactly what is the sodium content per serving size and what is the protein content per serving. Once you look at the labels of these things, it would dictate how much of this am I going to consume or how much am I going to prepare. I know it's something that we often overlook, but you would usually pick up a tin of corned beef and just cook it, and you wouldn't pay attention to the exact amount that you're putting into your plate, but based on the measurement, you can say, okay, if this contains X amount of protein, X amount of sodium, I can divide this into 4 portions and have it in 4 separate sittings, for example. So that would be like just a crude estimate.
Thank you so much. So I have 2 questions, I believe. First one was asked by Dr. William Brown. Does the ALB/creatinine ratio give a better parameter in CKD?
Could you repeat that for me?
Sure. Does the ALB/creatinine ratio give a better parameter in CKD?
Well, in terms of CKD, I would say it is it's easier on the patient. So it gives a good estimate. With the gold standard is going to be the 24-hour urine collection, but the 24-hour collection is it's based on patient compliance. It's a lot more cumbersome. The convenience of the spot test has pretty much taken the place of the 24-hour urine collection, unless there are select cases where you typically want to quantify over 24 hours the urine output. But as a prognostic indicator, I would say the spot albumin creatinine ratio is definitely more effective.
Thank you so much. From Dr. Cargill, could you repeat what you said about the effect of creatine powder and weight trainers? What alternatives are there for this group?
Okay, so what I said is that your level of creatinine is influenced by a number of factors. This is when we were explaining why we use creatinine to calculate the estimated GFR. And muscle mass, body weight, gender, age, those things impact the levels of creatinine, and your consumption of certain compounds that would then be converted to creatinine. So if you consume a lot of creatine as a bodybuilder or just as a fitness junkie, for example, you will tend to have a slightly higher creatinine if it is not flushed out of the system, or if you don't remain adequately hydrated. A lot of times on the labels, which we may tend to overlook or underestimate the importance of proper hydration, it will tend to impact your creatinine, which could skew your estimated GFR. Now, that being said, remember, we do not use solely the EGFR to assess for chronic kidney disease, because based on the EGFR alone, it might be misled to think that you have chronic kidney disease if really and truly what you need is to just drink more water. So in terms of the creatine, I would say just be mindful of the fact that it can impact your creatinine levels and the importance of hydration when taking these supplements.
Thank you so much. And the questions are coming in now. So I have another question from Dr. Brown. Does, forgive my pronunciation, does microhematuria affect measurement of protein urea when both are present? Apologies again, hopefully I didn't butcher that too much. So does microhematuria affect the measurement of proteinuria when both are present?
Okay, so the presence of hematuria and proteinuria in the same urine sample, we have to determine that that should be done in terms of a formal urinalysis. That should be conducted prior to quantifying the proteinuria, because you want to know in the presence of blood and protein in the urine, is this glomerular hematuria? Or glomerular hematuria meaning, is it coming from the kidney or is it coming from somewhere else, right? Is it a urological issue? Is it a menstrual issue? Is it a gynecological issue? You want to determine, one, this blood is coming from the kidney, and two, you want to determine whether this is an active urinary sediment. An active urinary sediment usually warrants a kidney biopsy, because that means that there is something actively damaging the integrity or the structure of the kidneys, and that needs to be evaluated, right? So usually the underlying conditions would be of paramount importance to take the whole clinical picture in context. So once it is determined that this hematuria is not coming from the kidney, then the presence of the microhematuria shouldn't really impact the reading of the proteinuria, although that hematuria should still be evaluated.
Thank you so much. Dr. Maxine Cargill, what are your thoughts on reducing the progression of SGLT2 inhibitors?
SGLT2 inhibitors, its use in chronic kidney disease, there have been a number of studies, the EMPA-REG, the DAPA trial, DAPA-CKD, a number of trials that have shown that these drugs are in fact very good at slowing the progression in terms of proteinuria, as well as impacting cardiovascular mortality and reducing hospitalizations, right? And I think in the DAPA-CKD in particular, there was even further work done on that study to show that whether the patient is diabetic or not, so even in your non-diabetic patients, it has shown benefit in terms of renal protection and cardio protection. So you will soon see patients that are not diabetic, if they fit the profile of being of high risk of CKD, they would be placed on an SGLT2 inhibitor. That's the direction things are going. So yes, those are very useful drugs in the management of CKD.
All right, this is a very wordy one here. What are the current treatment protocols for managing stage 2? As you advised, treatment due to delayed specialist appointment availability. But I usually refer immediately as I detect large levels of albuminuria with reduced GFR, while stabilizing to delay disease progression for specialist review and specific tailored management recommendations, which I then follow as the GP. Very verbose question. Hopefully you got it there. I can go again.
No, it was, I could have followed it completely, and I like the description, because what happens in practice, sometimes a general practitioner would refer a patient to the nephrologist, and for some reason the general practitioner may or may not see that patient again, and the patient then becomes a nephrology patient that is being followed up every 6 months or every year. So it's like, when do I refer, and what is the role of the nephrologist upon referring? So I would say part one, when you refer, as long as you have significant hematuria in excess of 300 milligrams per gram, I would say that is a referral because that needs further evaluation and potentially, if the cause is not found, possible a biopsy. Because even though we have the typical players, the diabetics, the hypertensives, which don't really have much proteinuria, but even though we have the chronic non-communicable diseases, there are other causes that account for proteinuria, your lupus patients, your glomerular disease, your genetic causes like your FSGS, your membranous nephritis, and that sort of thing. So I would say as long as there's significant proteinuria, you refer, right? However, the role of the nephrologist upon referral, if you have stage 2 or earlier, right, that would just be for an initial evaluation, and that patient follows up with his or her GP and sees the nephrologist once a year, right? So we would just monitor for progression, and the general practitioner sees the patient and monitors the patient for the majority of the time, right? The only time we would see them sooner than annually would be if you note that they have decline in their eGFR suddenly, or unexplained decline in the GFR, or they suddenly have proteinuria, and you realize that, okay, things are progressing way quicker than we have estimated. But for the most part, the onus is on the general practitioner to just get a brief assessment of overall CKD risk, cardiovascular risk, and if out of an abundance of caution, you decide to refer to your nephrologist, the nephrologist sees, assesses, and sends them back.
All right, thank you so much. I think we can take 2 more questions.
Right.
I have one here from Dr. Smith Green. How often do you see damage in the kidneys without loss of the numbers of nephrons? And do you see a reduced filtration in the single nephron filtration? And what could cause such a scenario?
How often do we see a decline without markers of CKD? If I'm not mistaken, that's the question.
Let me help you with that one, Sam. She's asking if you see damage in the kidneys without loss of the numbers of nephrons, and just a generalized reduction in the filtration rate of nephrons. What kind of scenario causes that?
That's
not loss of nephrons, but reduced across the board.
That's an interesting question. I would say if I'm presuming this is based on a biopsy, where it would show a reduction in the nephron number. Generally, as you age, your nephron number would decrease. So if this is a patient that is, I guess, aging, which is everyone, but a middle-aged to elderly patient, if you see a decline in the eGFR, it is because the patient is aging, and if they don't have any markers of CKD, they would lie in the green to yellow category, which would be they don't quite have CKD, but you should monitor them closely. If they're yellow, then that would be a moderate risk as opposed to a high or a very high risk patient. And this is where we implement the kidney disease, the kidney failure risk equation that I was speaking about, right? So if you see a patient with decline in eGFR, you pull up on your smartphones or on your computers, you pull up the kidney risk equation and plug in the values you see, you get an albumin creatinine ratio on that patient, and you determine what is their risk, what is their 5-year risk of progression to florid kidney failure. Now, if that risk is very low, I would say you don't necessarily have to do anything urgent. You just monitor. But if you have done that and you realize this patient is declining and the risk is high, then I would say refer. But not to sidetrack from how often do we see it, I haven't seen that often. That is the honest truth. I haven't seen it. I don't know if the other nephrologists can differ on that, but we generally don't see a decline in nephron number without markers of kidney damage.
Or vice versa.
or vice versa.
Perfect. All right. So we have 3 questions. They're really short. I'm going to try to merge them into one and then end this session, which has been really amazing. So first is how much NSAIDs could cause CKD. Second is how do you manage anemia from kidney disease? And I'll ask the third question when you finish those 2. So go ahead. Okay, so
NSAIDs, how do they cause CKD?
How much would cause CKD?
Or how much? Well, it depends on the extent of usage. So if you're a patient that is in chronic pain or have chronic inflammation and it requires you to take NSAIDs long term, then you are definitely at higher risk of acute kidney injury and progression to CKD because it leads to an interstitial nephritis and directly damages the nephrons and impacts the nephron number, right? And the function. Now, I would say if it's a one-off thing, the risk is much lower. However, if it's based on risk and there are alternatives available for pain management, I would say just avoid the NSAIDs. That's my opinion. And that is the opinion of many nephrologists. Now, it may not be feasible in all cases for persons that suffer with chronic pain, but in terms of pain management, I would say if you have a patient that happens to be needing or requiring NSAIDs for an extended period of time, it definitely needs to be re-evaluated in terms of their pain management because that can lead to long-standing, it will cause AKI, right? And it will lead to long-standing kidney damage. The second question was, how do you manage
anemia from kidney disease? Yes.
Okay, so anemia in kidney disease is due to a deficiency of erythropoietin, the hormone that is secreted by the kidneys. So as you get from a stage 3B and you progress further down, you find that the ability of the kidneys to produce this hormone decreases. Now, what we do for patients that are chronically anemic and let's say stage 5 or on dialysis, we usually give them a synthetic form of the hormone, which is Eprex or erythropoietin, basically injectables, right? They get that twice a week. But of course, we know that renal patients, they could get any form of anemia known to man. They can have iron deficiency anemia, they can have B12 deficiency, and they can have the anemia of chronic disease. Simply because of the dietary restrictions, some people really don't eat that much, the food tastes funny, that sort of thing. So replenishing those stores, meaning the iron stores, the B12, folic acid. So folate is most dialysis patients or renal patients are folate deficient. So replenishing those stores would be important in regenerating red blood cells. And if replenishment does not restore the patient to, I would say, a target of 10, because in anemic patients with CKD, usually going in excess of 10 increases their risk of thrombotic, or increases their risk of strokes, right? And adverse events. So if the blood count is not coming up with your initial methods, then that as a patient, you would probably consider for erythropoietin, meaning the injectable.
Thank you so much. And we literally have 10 seconds left to answer this one. My patient with hypertension and diabetes always has trace protein on dipstick. Any concern?
Trace protein on dipstick, I would say quantify it. Do a spot albumin creatinine ratio, ensure that they are an ACE inhibitor, and monitor the albumin creatinine ratio over time. You could up-titrate the dose of the ACE inhibitor. Your goal is to get them to a point where they are secreting less than 30 milligrams per gram of albuminuria.
Thank you so much, Dr. Chrysostom. Really appreciate the answers to those questions and the time that you've taken. At this time, we're going to go to our sponsors' presentation, after which we'll have the management of NCDs and chronic disease by Dr. Saibo.
Thank you.
Good morning. On behalf of AstraZeneca, I would like to thank you for this opportunity to sponsor the Association of General Practitioners Nephrology Conference. My name is Kevin Ferron, and I'm the Regional Sales Manager for AstraZeneca for cardiac brands in the Caribbean. Today, I'll be doing one of the sponsors spotlight. Really quickly, some of the objectives that we hope to achieve by this sponsor spotlight is to highlight the collective burden of cardiorenal complications of the type 2 diabetic patient, talk about the prevalence and burden of CKD, present or declare study, which was dapagliflozin's study, cardiovascular outcome study, and also to highlight some of the other studies that we have done, as well as to focus into the GP or the family physician's office to go beyond glucose management. Now, together, cardiovascular, kidney, and metabolic complications are the leading causes of death worldwide. If you look here, you see that almost 18 million people die of cardiovascular disease per year, 1.5 million people die from diabetes per year, and 1.2 million people die of kidney disease per year. And of course, diabetes is at the center of all of this. It affects the pump, leading to heart failure. It affects the plumbing, leading to atherosclerotic cardiovascular disease. And it affects the filter, leading to renal disease. Now, CKD is a progressive disease, but it is affected by multiple factors. As you can see here, some of them that we are commonly faced with in Jamaica, of course, are diabetes, hypertension, and obesity, not to mention smoking. So that is why it's important for us to also sponsor this conference, because globally we have a thirst to improve CKD awareness and to advocate for early screening of CKD. Now, the data shows that out of every 10 diabetic patients, almost 3 of them already have renal dysfunction. So you can think about your practice, your various practices, and to think about how much that means in terms of how many patients could have renal dysfunction in your practice. And globally, we can see here some data from 2019 that there are 463 million people living with diabetes, 64 million people living with heart failure, and 843 million people being affected by CKD. The data also shows that almost 60% of patients with type 2 diabetes will develop chronic kidney disease. And this slide just shows up generally, if you take a sample of the population, most persons would have stage 3 kidney disease. And that's a big deal. It means that, one, we're picking up patients very late. And two, it also talks about the mortality and the morbidity of the disease. You can think about stage 4 and 5 and wonder why the numbers are so low, but then also remember that patients with stage 3 kidney disease also could die of a heart attack and not progress to stage 4 and 5, for example. This slide basically just talks about the cardiovascular risk events and also the hospitalization as you decrease in EGFR. So the lower the EGFR is the more likely of cardiovascular events. Additionally, the lower the EGFR is the increase in hospitalization. And we talk about kidney disease, but it is a disease that affects not only the patient, but it affects the healthcare system, it affects the patient's family. So it's really a big burden on our societies globally, as well as in Jamaica. So really quickly, I want to go into DECLARE, which is dapagliflozin's CV outcome study. And this is the study design. Basically, we had about 17,160 patients. 60% of them had multiple risk factors, so primary prevention patients. And secondary prevention patients was about 40%. They were randomized on a 1-to-1, one arm being placebo, which is really standard of care for patients who had hypertension, dyslipidemia, and who were diabetic, as well as one arm with Forxiga or dapagliflozin added to standard of care. And there were 2 primary endpoints. First one was a composite of CV death, MI stroke, which is MACE, and a second primary endpoint was a composite of CV death or heart failure. And additionally, secondary endpoints, all-cause mortality and cardiorenal composite endpoint, which we will focus on that one today as this is our nephrology conference. Okay, just to highlight some differences between the SGLT2s that we have on the market in Jamaica. Of course, as I mentioned before, DECLARE, which is AstraZeneca's fourth SIGA CV outcome trial, has 17,160 patients. So it's the largest CV outcome trial in the world. And also there's a difference in terms of the patient population in each of these studies. As you can see, EMPA-REG had 7,000 patients, but 100% of them had established cardiovascular disease, meaning they already had some form of event already. These were secondary prevention patients. CANVAS had 34% of patients having primary prevention, meaning they've never had a cardiovascular disease. And then we spoke about DECLARE, meaning showing that we had 60% of patients who were primary prevention patients and 40% secondary prevention patients. What this really means is that DECLARE is more representative of a GP study, patients that you'd see normally. If you think about 10 of your patients, you would say hopefully at least six out of 10 of them have not had an event yet. And so that's the difference between the three studies you can see here. Okay, to just look at quickly at the primary endpoints, we can see that at the end of 4 years, 4-SIGA or dapagliflozin had a 17% reduction in hospitalization for heart failure and cardiovascular death, and a 7% reduction in MACE. But today we'll definitely focus on the renal endpoint, which was the secondary endpoint. And from the DECLARE study, I'll show you in another slide, this had led to 2 other trials, pivotal trials for SGLT2s globally. So DECLARE showed that there was almost a 47% reduction in the slowing of renal disease progression with type 2 diabetes. And this is with predominantly patients with preserved renal function. And I think this was very eye-opening because this is what led to further studies, a study called DAPA-CKD. But think about it, if there was a drug that there's a possibility that you could almost cut in half the renal risk, I mean, that is fantastic for these patients. We see how many people suffer globally with CKD, and adding a drug like this to their regimen with the possibility of cutting their disease risk in half is fantastic news for the patients. Just really quickly, just to show you the progression of the studies. So this is DECLARE, which we just mentioned. We just spoke about the secondary endpoint in terms of renal disease and the 47% risk reduction. After that, we did DAPA-HF, which focused on HFrEF patients with or without diabetes. The key point in this one, not only was the reduction, about a 26% reduction in hospitalization for heart failure or urgent heart failure visit, but one of the hardest, I guess, endpoints to really prove is all-cause mortality. And it showed a 17% reduction in all-cause mortality for these patients, and that was fantastic. And then after that, we did DAPA-CKD, which I suspect some of the speakers today will mention. But this one actually showed some magnificent data for CKD patients. I think this one is probably the study that led to the nephrologists raising their hand and saying, no, we want this drug too. So we moved from being a drug for type 2 diabetes to a drug that the cardiologist wants, so now a drug that the nephrologist want. And that basically means that you can fit 4-SIGA or dapagliflozin in your practice in different types of patients. So in the DAPA-CKD trial, there was a 39% reduction in your eGFR decline, end-stage kidney disease, or renal or CV death. And then also landmark is a 31% reduction in all-cause mortality. So I mean, that is really powerful data. And I'm sure a lot of the speakers will speak about that data today, along with the use of other SGLT2s in chronic kidney disease. So as I wrap up, I want to take you forward to your office tomorrow. We already hear that almost 3 out of 10 of your diabetic patients have some form of renal dysfunction. And also, out of those 10 diabetics that you might have in your practice, there's a possibility that 6 out of 10 of them can develop chronic kidney disease. So if you have a new or existing type 2 diabetic patient in front of you tomorrow, what we're asking you to do is the following. Definitely monitor for cardiorenal complications. Also, critically, is to screen for chronic kidney disease. I think there's also some data to say that out of every 7 patients that are diagnosed with chronic kidney disease, only 1 of them actually had a record of this. So it's very important for us to improve and to increase the screening that we do in Jamaica. And then not only that, but please don't only treat HbA1c for your diabetic patients. Yes, HbA1c is critical, it's very important, but also start thinking about adding agents that go beyond glucose management to offer cardiorenal protection, like SGLT2s and like Forxiga, like dapagliflozin. So if we were to ask many of the doctors online today, what is their go-to when they are treating diabetes? They would speak about molecules like sulfonylurea, including glycoside, DPP4s, metformin, and insulin. As you will hear throughout the course of this conference, and as you check all the guidelines in terms of managing diabetes, insulin and metformin are mainstays. What is happening now is that they're including SGLT2s just below metformin, and that is because of all of these effects that it has. So as you can see here, what is being used a lot in Jamaica is sulfonylureas and DPP4s, but that's really glucocentric and focusing on treating the hyperglycemia, which, yes, is important, but there are other factors that we need to think about when we're managing these diabetic patients because they can develop complications, right? So you can see here, these are the glycemic effects of SGLT2 inhibitors. Treating hyperglycemia, similar to what we do now with the sulfonylureas and DPP4s, but also they can improve the beta cell function, decrease insulin resistance, and decrease glucotoxicity. Some of these, the sulfonylureas and the DPP4s do. They don't increase beta cell function. They don't decrease body weight. And also, we are looking on the right-hand side of my screen, which is the extra glycemic effects of SGLT2s. And these were later studied after the clear. So you're looking at decrease in the interstitial fluid, decrease in the plasma volume, decrease in hematopoiesis, decrease in your blood pressure, decrease in glomerular pressure. And this, of course, comes into what we're talking about today at the nephrology conference. So
thank you so much.
My take-home message to you guys today is I would love for you to get more experience with Forxiga and with Zigduo. To date in Jamaica, we have about 1,200 or 1,300 patients on Forxiga and Zigduo. For the most part, we've been getting many success stories. Patients have been losing weight, patients have been feeling better. So I implore you to use a drug not only to treat HbA1c, but to also prevent cardiorenal complications, and also to think about drugs that prove all-cause mortality, which, as I said, is a very difficult endpoint to prove, which basically means that compared to standard of care, patients died less on Forxiga versus standard of care. So just a reminder, we have 4 presentations in Jamaica at this time. We have the Forxiga 5 mg and 10 mg. Standard dose is the 10 mg. 5 mg was really created for persons who have severe hepatic impairment. But of course, in some countries, they do start at the 5 and titrate up to the 10. But really and truly, all the studies that I showed you today use the 10 mg as the standard dose. And then especially for your newly diabetic patients, you can think about adding Zigduo XR. So think about that patient that you need to put on metformin, newly diagnosed, but you realize that based on the HbA1c, they're gonna need more than just one agent, or a type 2 diabetic patient who you want to give cardiorenal protection to, and you also want to reduce a pill burden. We have Zigduo XR. So it's, of course, the combination of dapagliflozin and metformin XR. We have 2 presentations, the 5 mg 1,000 and the 10 mg 1,000. Now, all 4 of these presentations were meant to give once daily. However, if you need to get to 2 grams of metformin, you can take 2 tablets of the 5 mg 1,000 once daily. And of course, for the 10 mg 1,000 is just 1 tablet once daily. Thank you very much for this opportunity, and I hope you enjoy the rest of the conference.
Thank you, and keep your samples coming. They're very helpful. At this time, we're going to hear from Dr. Saibo, who is no stranger to us at all. He's a graduate of the University of the West Indies, both MBBS and DM programs. His professional experience includes working as the chief resident at the University Hospital of the West Indies since 2009. He's currently the consultant nephrologist in the Department of Medicine and the senior lecturer with the University of the West Indies. He has published extensively in peer-reviewed journals overseas, the Renal Registry in Jamaica, and is a technical coordinator for the Caribbean Institute of Nephrology. Dr. Saiba, thank you so much for presenting this morning. We look forward to your presentation.
Thank you very much, and good morning, everyone, on a beautiful Sunday like this. So the opening presentation was a very useful batsman, if I may use the same analogy that Dr. Chrysostom started. I just hope that I can continue to bat. My experience with cricket and the West Indies has always been, you know, they start off really good, and then when they have at least maybe 3, forgive my non-familiarity with the cricket terms, when they have maybe about 4 runs to win, and they have maybe 5 or so wickets, they still never make it. So that was a major turnoff for me to cricket when I first came to this country. So I hope that I can continue to bat the way Dr. Chrysostom started. So just to try and make things light, the overview of what I'll be talking about, where we look at the prevalence of chronic non-communicable disease. We'll look at risk factors for CKD progression, because it's important to know what the risk factors are in order to try and reduce the progression, because what we're trying to do is really try and prevent those persons who have kidney disease from progressing rapidly, although we know that sometimes that their progression, you know, they may not get to stage 5, but they may have cardiovascular disease. So it's very important that risk factors be managed in these persons. And then we talk about management, selecting specific things, and I don't think I have anything new to give you guys in order to, you know, to digest. So this is just going to be a very light meal, and then we summarize. So this is a poll question. So I'm not sure if we can sort of go to the poll, and I'll give you like 30 seconds. So which one of the statement is accurate about chronic kidney disease in Jamaica? So to look at chronic kidney disease, we have chronic non-communicable disease, diabetes mellitus, and HIV. Unknown due to data, inaccurate CKD prevalence. So as Dr. Chrysostom mentioned earlier on, or is it sickle cell disease is the 3rd most common cause? Do we have the result of the poll? Okay, so yes, this is great. So I don't have anything new to share with you guys. But so let's look at chronic non-communicable disease in Jamaica in terms of prevalence. So this is something that, you know, we recognize globally, and you can project this with diabetes, you can project it with hypertension, you know. So CKD is recognized as a global public health problem. And within the Latin America, as more information is available, we can see that there's a general trend all the way from Latin America to South Africa to Europe. And of course, Jamaica is not any different. So if you look at worldwide in 2013, about 18 to 16% was thought to have CKD, whereas in the United States, it was 11.5, and as time goes on, the numbers increases. And in 2016, they found out that we've now gone to like about 13.4%. In Jamaica, one of the very first study that attempted to look at the prevalence of CKD done by Professor Barton et al. Found that, you know, prevalence was 327 per million, and that was in 1993. The definition for CKD at that time was different. It was defined as chronic renal failure with a serum creatinine greater than 150. Now we know that KDIGO guideline has changed, and it has, you know, changed the way we define CKD for uniformity. Numbers from the Caribbean Renal Registry, we have about 2,700 patients with different stages. Now, this data is only coming from 4 main parishes. So as you can imagine, this is a gross underestimate. We have more than 800 people receiving dialysis. Unfortunately, about 2/3 of persons who are supposed to be getting dialysis cannot get dialysis either because of cost or availability, or they may have some underlying disease. Now, we have come a long way in terms of chronic disease and dialysis, because in the past, if you have any underlying malignancy, dialysis was not offered. And as some of you may realize, that we have a lot more people now on dialysis who have underlying malignancies, especially multiple myeloma. And just to share something from the Jamaican Health and Lifestyle Survey, just so you can see the progression of what is happening. Obesity, hypertension, diabetes, high cholesterol, these are all chronic non-communicable disease, and their prevalence is increasing. Unfortunately, their level of control is not increasing, as you can imagine, which means therefore that obesity has gone up to 29%, hypertension at 57%, diabetes increased to 11.9%. And therefore, which means that the control, which is poor in all of them, will lead to complication. And as we know, in an attempt to give you an estimate from the same group, Professor Wilkes and Trevor Ferguson, they have an estimated 15% of Jamaicans 18 years and older to have chronic kidney disease. So this is not something to be taken lightly. But despite the growing burden, unfortunately, we still have less than 50% of persons being diagnosed, which is why it is very important in terms of primary care information and registry, that we need to know what is happening at the level of those persons who have not been referred to either the internist, to hypertension specialist, or any other kind of documentation of their stage or level of kidney damage. So it's going to be important for us to continue to screen those persons who are at risk, document, as has been said earlier on by Dr. Chrysostom, so that we can have a reasonable idea of what is the growing burden. And as you can imagine, this is something that we need in order for us to make recommendation to the legislator, and also for the government to have better allocation of healthcare resources. I can share a little story where CKD was something that was never thought of in terms of consumption of blood transfusion in the early stages when erythropoietin was not available. So a lot of patients who have CKD, the question was asked about the management of anemia. We used to have to do blood transfusion in those days. And the blood bank will always have issues, like, oh, Dr. Shoibo, your patients with CKD are consuming all the blood. In as much as we try to, at least show some, good faith or goodwill by having the annual blood drive just for, patients with CKD, until eventually erythropoietin became available and the National Health Fund decided to put it on the formulary. And we can see that there's uptake by a lot of patients. So it's important to know what the burden of these diseases, the disease is. So this is the most recent data that was presented this year at the annual Nephrology conference. And basically it looks at the underlying cause of CKD from diabetes, mellitus, and hypertension. Hypertension still is the main cause and is much more prevalent in male compared to female, whereas diabetes is slightly reversed, is much more common in female compared to male. The question on the distribution of CKD. So when the registry first started, we started a registry looking at patients on dialysis. So you can see that if you were to look in 2007 of the distribution, it seems like a lot of our patients have CKD stage 5. And then the question will be, we're diagnosing all these persons late. But that's really not the point, or that's really not the case. It's just because a matter of persons were being captured at the later stage of kidney disease. And as time progresses, what we have is now including those persons who have different stages of CKD. And as we can see here, stage 1, it's the prevalence of stage 1 seems to be increasing. And when we fast forward all the way to 2011, we still see the same kind of pattern. But this is because a lot of our patients are being captured in the renal clinic that have been established right across the island. So like St. Anne's Bay Hospital, Mandeville Regional Hospital, at Cornwall Regional Hospital, and at Spanish Town Hospital being the newest addition to the block. And what you'll find is that most of these patients present in the early stages because of early referral, and it's mostly because if you look at their age, they're in the younger age group, and these are people who have glomerular disease. So these are the people who present with proteinuria, these are the people who present with hematuria, or just unexplained impaired renal function. And these are the ones that are more likely to get a kidney biopsy done. And then the second highest, as you can see, is stage 3. And as we all know, cardiovascular disease is an increased cause of mortality. So you have less people actually getting to stage 5. All right, so we're moving on to risk factors for CKD progression. And this is the next poll question. So the question is, which statement is false regarding CKD progression? So 1, CKD staging and risk categories is a marker of cardiovascular disease. Hyperuricemia is not yet known as a risk factor because it can exist without CKD. Abnormal serum creatinine is not a reliable marker of CKD, and endothelial dysfunction is a common pathway in albuminuria. So let's see what the answer is.
I will just allow about 5 seconds more.
Okay, sure, no problem. So as you can see, some of these questions are, relevant, especially with the first presentation. Some of these are being answered. So we have a lot of persons choosing hyperuricemia is not yet known as a risk factor. This is not the scope of this presentation, but it's something that we need to know that there's some other markers of disease progression or risk factors that we need to entertain beyond just what we're going to be speaking about in this presentation.
So the results are up on the screen now.
Sorry, what did you say?
The results are up now. You should be able to see them, I'm hoping.
Okay. So risk factors for CKD progression. So we have, things that you can think about that are modifiable and those that are non-modifiable, if you want to think about it in a way. And there are those that are going to develop as a result of the cause of CKD. And then those that would develop as a complication of CKD. All of these will cause an increased risk of progression. So like race, gender, especially, men have more nephrons than women. Blacks have more nephrons than Caucasian. As we get older, the kidney also ages, and some of the things that we will have done during our lifetime will predispose to reduction in nephron mass. And the cause of CKD also is going to be a risk for progression. Smoking, if you smoke, definitely you're going to have a faster progression compared to those persons who are non-smoker. The presence of proteinuria, or even more specific, albuminuria, means there's some level of tubular damage because of reabsorption. So you're going to end up with increased progression. Hypertension, whether this is the primary cause of the CKD or develops as a secondary disease because of activation of the renin-angiotensin-aldosterone axis, will also cause CKD progression faster. Hyperlipidemia, as was mentioned earlier on, you can think about the blood vessels, stiffening of the blood vessels and increase in your central aortic pressure. These things will also cause CKD progression. Obesity will cause increased burden on the nephrons, with initially starting off with hyperfiltration in order to compensate. And unfortunately, with hyperfiltration or any state of hyperfiltration will lead to glomerulosclerosis. It's like asking Usain Bolt to run at the same speed of 100 meters in an 800-meter race. It's going to be almost impossible to run at the same speed. So any kidney that undergoes hyperfiltration, something needs to be done in order to prevent progression of CKD. And of course, GFR level, the higher state of GFR, the more the progression, and hence why in terms of recommendation for follow-up, it's different based on the stages of GFR, moving from G1 all the way down to G5. And of course, also GFR in itself will lead to an increased incidence or increased incidence of AKI. Now, AKI can be affected by hospitalization, can be affected by infection. Also, the use of nephrotoxic agent can also cause AKI on CKD, which is an acute kidney injury on top of chronic CKD, chronic kidney disease. So which means a patient who has chronic kidney disease, who develops repeated AKI, is more likely to progress compared to a patient with CKD without acute kidney injury. The presence of anemia, which is a complication of CKD, also will cause increased progression. Now, just to stick a pin earlier on with the question about anemia. Anemia of chronic kidney disease is due to low erythropoietin production, but we expect anemia, as was said earlier on, at a certain stage of likely 3B, stage 3B going up to stage 5. But sometimes anemia, the presence of anemia can be very subtle. So for the average male with a hemoglobin of 4.5, they may drop to 13.5, which may not be seen as as anemia, or they may even drop to 12.5. So if you're not watching the trend, you may not start to see that decline, and you need to advise the patient likewise. But also importantly, if we're not familiar with the recognition, you may see anemia in a patient who also has CKD, but the anemia is not because of the CKD. It is because of an underlying disease. And God forbid, in the elderly population, we always are concerned about non-benign lesion. Then we have CKD, mineral metabolic bone disease disorder. And what you find is the development of CKD will lead to eventually in a state of hypocalcemia, hyperphosphatemia, and increased level of parathyroid hormone level, which will cause changes not just in the bone, but also in the vascular bed. And this will lead to increased cardiovascular disease. It will lead to deposits, which can be painful, which can also lead to increased morbidity and mortality. And then we have hyperuricemia. Hyperuricemia in itself can be a marker of chronic kidney disease. And also hyperuricemia unabated will cause increased risk of progression for kidney disease. Now, this was already gone through eloquently by Dr. Chrysostom, but just suffice to say that when we are labeling our patient with CKD, I think it's important to put the cause, to put the GFR, which will tell you what the stage is, and also if they have albuminuria. this will not only help in terms of having it clear in the minds as to the cause and the stage of the patient's CKD, but it also helps us to track if there are any changes in the disease process. Now, referral at this point, if the cause of CKD is known and is solidified, then there's really no major issue. But if you're unsure of the cause of the CKD, it is important to have the preliminary investigations done, have the patient referred, so you know what the cause is, and then the management of those patients become important for the general practitioner or from the referring physician, because those patients have to have blood pressure checks. If they have diabetes, needs to be checked, and they need to monitor them to make sure that they themselves are keeping with guideline recommendation to avoid things that can cause progression of the disease. And this grid also, this rubric also gives you an idea of the risk stratification for cardiovascular disease for this patient. And as you can see, the presence of albuminuria at any point in time increases, at least moderately, risk of cardiovascular event and progression in this patient. So it's important to know this so as to be able to guide the management of our patient. Now, in terms of evaluation, just roughly, after we've gone through the cause, the GFR, and the stage, you want to always answer the question, is this CKD? Evaluation of chronicity. And there are certain things that we look for to evaluate a patient that may have chronic kidney disease. So we look for evidence. So if they have anything that has happened in the past, and 3 months later is still persistent. So it could be that they have reduced GFR, you've ruled out an acute kidney injury, the patient is well hydrated. Even sometimes for those subtle cases, you might have to advise the patient to stay off doing any kind of vigorous exercise so as to keep down the creatinine, because as you know, the GFR is going to be calculated based on creatinine, whether you're using CKD epi or MDRD equation. So it's important that we rule out all the different causes, all the different things that can give a false reading either in the GFR, either in the creatinine, or if you're using a 24 urine collection to calculate creatinine clearance, that could also be done in a particular selected cases that you're not sure, but you have to ensure that there's proper collection of urine, and the patient is advised usually to do it on a Sunday, because most persons, unless for those who will go to church and spend 5 hours in church, you can do the test on a Sunday. And reason being, you can collect the urine from early Sunday morning all the way into early Monday morning. There will be no need for storage of the urine sample in your fridge. You can take it directly to the lab Monday morning, and where blood test is also drawn. So you can compare and you can calculate your creatinine clearance, which can now be used as a surrogate for the GFR. Other things that we want to look at also is like an ultrasound. Ultrasound, although is user dependent, you can use an ultrasound to determine whether this person has chronic kidney disease or not, based on the fact that there's certain descriptive terms that is used, like loss of cortical medullary differentiation, if they say that the kidney is hyperechoic, and also the size of the kidney. Obviously, you don't want a small shrunken kidney to be diagnosed in CKD, because then it usually means that the patient is presenting at a late stage. Evaluation of the cause depends on how comfortable you are with the likely cause. And sometimes, a question was posed in a diabetic hypertensive person who may have proteinuria or albuminuria, or they may have hematuria. Those things are common or can happen in hypertension and diabetes, but we have to be careful that we're not missing other causes of hematuria, especially in the presence of red blood cell cast in a urine sample. So if you see albumin and blood in dipstick urine, it is usually advised to follow that up with a urine microscopy and urine analysis. Now, this was mentioned earlier on also in terms of evaluation, but it makes sense that you can use measurement of cystatin. It is available in Jamaica, but it's something that we use mostly for research. But you can look at the eGFR using cystatin compared to creatinine in a case where you really need to confirm whether this person has CKD or not. But invariably, time will tell whether you have CKD if you monitor the patient and you look at the level of control for the patient, meaning looking at the level of GFR as time goes on. Now, the question was asked about evaluation of albuminuria. So it is largely now superseded by what you call a spot albumin to creatinine ratio or spot protein to creatinine ratio. The only thing that I will advise, or it's recommended, that this must be done on an early morning sample of urine, because even albumin excretion by the kidney, it's sort of variable and it follows almost a wave-like pattern. So you want to capture the maximum albumin excretion, which is best if the patient, imagine the patient is producing urine and albumin overnight, all of that is mixed within the bladder. So the first sample of urine will give you a representation of their average albumin production. So what I will advise is for the patient to get the container from the lab, just like the 24-hour urine collection from the night previously. So that way they can, when they wake up, they can feel comfortable to empty their bladder and get a sample of that urine in the container, and they will take it down to the lab. Now, we can use our reagent strips for total protein using automated reading, or we can just use the regular strips by manually just looking at it. These are very useful, especially when you're monitoring the patient. So a patient who has micro or albuminuria between 30 and 300 may not be positive on your regular strip, whereas if they are over 300, then it becomes positive. So a patient that you may suspect might have, well, in the old nomenclature, microalbuminuria, you can send them to get the albumin creatinine ratio test done within the lab, along with the urine microscopy and urine analysis. So why is it important, albuminuria? Because when you move from albumin albumin creatinine ratio of 30 to all the way to 300, there's a linear increase in the cardiovascular risk for these patients. So it's important that anybody who has albuminuria, whether they have diabetes, whether they have hypertension, whether they have heart failure, whether they have primary glomerular disease, it is important to monitor the albuminuria and find measures to reduce the albuminuria so therefore you can reduce their cardiovascular risk. And this is exemplified in this study. Also, there's a linear reversal relationship between GFR and cardiovascular risk, meaning the lower your GFR, the higher your risk of developing cardiovascular outcome. Now, hyperfiltration is something that we need to understand, right? So you might do a creatinine for somebody and the creatinine comes back at 55. And when you calculate the GFR is 150. In a 50-year-old person, That is abnormal. It is not normal, because we know that if you have a high or hyperfiltrating kidney, it drives your GFR decline quicker, because the higher the GFR, the more likely damage you will cause to the tubular cells, and destruction of your tubular cells, just like albuminuria, will lead to quicker or faster decline in your reabsorptive and secretive properties of those tubules, and hence you're going to see an elevation in your creatinine quicker than normal. And this is also exemplified. And if you look at just a general population with proteinuria, so if you see proteinuria, chances that they're going to have hyperfiltration. And if you look at those persons with kidney hyperfiltration and without kidney hyperfiltration, for those who have kidney hyperfiltration, the cumulative risk of proteinuria is much, much higher. So you will see that correlation between hyperfiltration and proteinuria or albuminuria. It's also important that when you see proteinuria, which is non-selective, non-selective proteinuria, you always have to start to imagine, is there something else that is causing this problem? So we need to start to look at diseases or systemic problem that can lead to kidney damage. What about erectile dysfunction? So a patient was referred to me, or a patient came to me, which I found very interesting, some years ago. And most of the consult, this is a dialysis patient who's been managed by his doctor, who sounds like everything has been done appropriately. And at the back of my mind, I'm wondering, okay, why is this patient here? Are they here for a second opinion? This person has been on dialysis for 5 years. Why second opinion at this stage? Only to find out that the patient, because of, we do have a couple publications along with Dr. Ho, who is in this forum, on sexual dysfunction in the dialysis patient. So they thought that, I was an expert on that. So let me just put it out there. I'm not an expert in erectile or sexual dysfunction, but we can have a conversation with the patient to try and guide them as to the best treatment option. But in this paper, in this review, what it looks at is the presentation of hypertension. Now, most times, most people in the long years will present with stroke or cardiovascular event before they're diagnosed with hypertension. But what we need to understand is that erectile dysfunction is also a possible presentation of hypertension. And it is actually said by Jackson, which, provocative in 2006, that says a man with erectile dysfunction with no cardiac symptoms is a cardiac patient until proven otherwise. And why is that? It's because ED by itself is an independent risk factor for cardiovascular disease. It was actually made equivalent to a person who is a moderate smoker. Men who have ED, on average, will present 36 months later with chest pain. So which means once they have the ED, they already have cardiovascular risk, they already have endothelial dysfunction. And why is that? Because the arteries in the penis are much smaller in diameter than the coronary arteries. So atherosclerosis and the plaque formation would be more significant and present earlier in this person. So it's important that we ask or we screen for these things. A nice simple way of doing it is just to have a questionnaire in the waiting room when they're seated and ask those questions. Obviously, questions being asked of a man, it's going to be different in response when the spouse is also present. So you can try and find a way to try and get the best response from them. What about smoking as a risk factor? So smoking in Jamaica, so when this study was done, the current smoking rate based on Jamaican Health and Lifestyle Study 2 was 14.5%. But when you look at this ESRD patient on dialysis, current smoking rate prevalence was almost as high as 40%. So it is important that we advise our patient about cigarette smoking. I do not have any, or I have not seen any studies that looked at, you know, the use of marijuana or any of its breakdown product and the CKD progression. So I'm not sure if there are others in the group who has such information. So let's look at just briefly an overview of how do we manage this disease process. So we go back to the poll questions. Which statement is false in the management of CKD, or in the management of chronic non-communicable disease in CKD? So the first one is renin-angiotensin system inhibitors is indicated even in the absence of elevated blood pressure. Hyperfiltration is a good marker of a stable CKD and allows for long-term follow-up. Lowering HbA1c is an important step in the management of diabetic kidney disease, and use of SGLT2 inhibitors indicated in management of CKD and albuminuria regardless of diabetes status. So which one is not the right answer? Okay, excellent. So majority of people, 60%, thinks that B, hyperfiltration, is actually a bad mark of CKD, definitely not stable CKD, and those patients need to be followed up. You need to be followed up closely. For those persons that selected renin-angiotensin system inhibitors, it was said earlier on by the first presenter, in terms of the use of renin-angiotensin system inhibitor for those persons who have diabetes or they have albuminuria. The basic idea is to try and reduce the glomerular filtration pressure. If you reduce glomerular filtration pressure using renin-angiotensin aldosterone blockade, what happens is you reduce the pressure that the tubular cells are exposed to, and that tends to help in terms of reduction in progression. Lowering HbA1c is important in management of diabetic kidney disease, so as well as high blood pressure. So remember, diabetic tend to have, you know, proteinuria or albuminuria, so it's going to be important to use renin-angiotensin system blocker. And then this is the highlight, you know, some of us are probably familiar with the use of SGLT2, but the indication in persons who have CKD, that I think will be highlighted later on, but I do have 1 or 2 slides on that. So the management of any chronic disease, even CKD, and the causes of CKD, always should begin with therapeutic or total lifestyle changes, including nutrition. That's important. We need to screen for hypertension. We need to screen for elevated blood pressure. There was a presentation that I did in the month of June at a conference, at a cardiology conference. And one of the things that, you know, highlighted is the definition of diabetic kidney disease. What they found in a particular study of persons who had diabetic kidney disease. Now, we usually look for hyperfiltration and we look for albuminuria. But what they found using home blood pressure measurement, where that more than 50% of these people were already developing changes in their blood pressure level prior to even having being diagnosed with diabetic kidney disease. So arterial hypertension may just be included in the guideline definition of diabetic kidney disease. So it's important that we measure blood pressure in anybody with kidney disease, because hypertension in by itself will lead to progressive loss of nephrons. We will speak just 1 or 2 slides on diabetes. There's a role for this lipid treatment, although some of these guidelines are controversial, and then updates from KDIGO has not been out as yet. And then we'll speak about just a few other things in terms of management. So why do we need to treat renal disease or treat the chronic non-communicable disease? It's just simply because we want to reduce their cardiovascular outcome. We want to improve their mortality and we want to improve their morbidity. However, we have to understand that there's a tight link between the kidneys and the cardiovascular system. If you have any disease of acute or chronic disorder in one, it will lead to disease process in the other. So some of you might be familiar with cardiorenal syndrome. So you can have the type 1, type 2, then type 3 and type 4, which I call the renal cardiac syndrome, because the problem starts within the kidney affecting the heart. So you can have a back and forth interrelationship, because what we know is that CKD patients are more likely to die of heart disease than to advance to ESRD. So then what do we need to do differently for this person? So if you have CKD, if you have albuminuria, you have to be treated as having at least moderate increased risk of cardiovascular, and that should be treated as such, which means referral when needed to the cardiologist, do the necessary investigation so that you can reduce their mortality and morbidity. So, lifestyle modification. We spoke earlier on about diet. So I didn't put, amount of grams of protein or grams of salt. But what is important, if you can adopt a DASH trial with diet, which may be useful in some patients, but importantly, we have to reduce sodium intake and increase potassium intake. And then the patient freezes and they look at me and they say, well, doc, what are you talking about? Of course, we have to monitor the serum potassium. It is important that we monitor serum potassium in anybody with CKD, because one, CKD by itself will cause hyperkalemia, or there are renal tubular disorders that predisposes to hyperkalemia. Some will predispose to hypokalemia. Also, we know that hypokalemia is not very good in a patient that has congestive cardiac failure. So we need to monitor these diseases, this electrolyte, to make sure that the patient is appropriately prescribed the normal or whatever the amount of potassium is required. Now, losing weight, not just when they're obese or overweight, but losing weight is also important in patients who have chronic kidney disease. It not only helps the chronic kidney disease or the amount of work that the kidney has to do, but we know that it also helps the cardiovascular outcome. It affects the diabetes control, the blood pressure control. There's a certain amount of weight that is lost, and which corresponds to a particular level of reduction in both diastolic and systolic. There was a study that was done a long, long time ago that actually looked at TLC in reducing the control of diabetes by up to 50%. So we have to incorporate this in patients who have CKD in order to reduce their mortality and morbidity. What about exercise? They need to exercise based on their level of sedentary. So somebody who has a sedentary lifestyle, basically do nothing, we have to improve the exercise by allowing them to increase the activities of daily living. So going to the kitchen, going to the bathing, small things like that. They make baby steps. And once they can tolerate that, then we can graduate them to 150 minutes of light or moderate exercise. Then we can increase them to vigorous exercise. But this is important to increase their exercise tolerance. Also, moderate alcohol intake, only if the alcohol intake is excessive. If they're not excessive, it doesn't really change the cardiovascular outcome. Now, this slide will look a little bit busy, but what I just want to highlight is protein as well as their water intake. So if you look at the protein for those persons, it is important in order to reduce their progression and development of uremic symptoms, to reduce their protein intake. And typically we go to 0.8 to 1 grams per kilograms per day. But we have to be careful that we do not cause malnutrition, because if malnutrition gets on board, then those patients also have a worse outcome, especially when they're going to renal replacement therapy. So it's important that the patient is not malnourished. Now, this is going to be important in those patients not with CKD and diabetes, but those persons who have CKD and underlying malignancy. Because you will note, even their malignancy, they have reduced appetite, they have an increased metabolism due to the burden of the disease. So those kind of people, you have to be, a bit mindful of how you restrict their protein intake so as to match their dietary requirement. And then at the bottom, as I said, is the water intake. So there's a difference between CKD patients who still passes urine, meaning non-oliguric, they pass more than 400 or 500 cc per day, compared to those who are severely oliguric, because oliguria allows you to manage patient differently from those who are non-oliguric. So a patient who is non-oliguric with heart failure is more likely to respond to diuretic compared to a patient who is anuric, who may not respond to diuretic therapy. Now, the amount of urine that is passed progressively decline as you move from stage 3B all the way to 5. Even for those persons who are on maintenance hemodialysis, there's a thing called residual renal function. As the residual renal function reduces over time, you will notice that their blood pressure control becomes a bit more difficult. You might even have to increase their dialysis frequency from 2 to 3 times. You might even have to increase their dialysis duration because of this progressive loss of residual renal function. But it is important that when we are referring this person, that we're in constant dialogue and communication with the nutritionist, because when they go to the nutritionist and they're being prescribed, it's important that we can interpret to the patient. And what I usually tend to use, okay, it's not there, but I guess somewhere along the line, I will show the slide. But, I usually just draw a circle and I show them what's the distribution, but I do think I have a slide on that later on. So cardiovascular disease is the cornerstone of what we're trying to prevent. So we go through the lifestyle, modifiable or modification, diet, physical exercise, stop smoking, drinking, reduce your stress, but there are genetic factors that we cannot change. These are the unmodifiable factors. Then we have the risk factors in the middle, and then the risk factors are the ones coupled with the lifestyle that's going to present as cardiovascular disease, either with stroke or coronary artery disease. And the central obesity, metabolic syndrome, diabetes, all of this will lead to high blood pressure. What we want is to have the patient at the primary stage so we can reduce it. When we don't want them at the stage when they've already had the stroke or the coronary artery disease or they've got the CKD, and then we're trying to do secondary prevention at that stage. I put this slide there because when we speak of blood pressure management, we're looking at a figure that is very variable. So it's important that we project this slide. We can get this from KDIGO website and have it so that all the secretary or the nursing aide and even the patient understand that when they're doing blood pressure, most of these criteria should be met because we're using a figure to guide the management of a patient. Now, we could argue as to whether intensive blood pressure is good or moderate blood pressure lowering is good. But if you look at the difference in the study that looked at intensive, meaning using the sprint, so blood pressure less than 120/80, or using the regular 130/80, if you follow the patient for over 5 years, the difference in the reduction in GFR is just 3 mils or 3 to 4 mils. So which is not really, really significant. But if you look at their cardiovascular benefit, then you can see that reducing the blood pressure better gives you cardiovascular benefit. Of course, we have to avoid having the patient who has hypotension because we don't want to cause other problems. But I recommend that you have this blood pressure measurement figure in your office so that you can have some level of confidence when you interpret blood pressure when the patient presents to you in your office. We all know about the white coat effect, and this is a study that looked at that. And basically what this is comparing what the nurse's blood pressure measurement and the doctor's measurement during office visit, and there's a big difference because there's a higher systolic and diastolic for the doctors and reduce when the nurses does the measurement, it's less. Although with every subsequent visit, the chances of having that effect goes down, but it also goes down with the nurse monitoring the blood pressure. But this is just to exemplify the fact that some of us will still prefer to do our own blood pressure when the patient presents in the office, apart from what is done on the outside. It's also important if you have any issues to use 24-hour ambulatory blood pressure measurement so you can see what the level of control is for your patient, or even you can just advise the patient to buy their own blood pressure machine and check their blood pressure at home. So at every visit, you can see what their trending blood pressure is, and you can compare the average of those blood pressure with your blood pressure machine. In persons who have diabetes or no diabetes, cardiovascular event is very important. So we need to start renin-angiotensin inhibitor, whether you want to do ACE or ARB, for high blood pressure when they have CKD or when they have albuminuria. This is a class 1B recommendation by KDOGI. And the reason is because all of these trials that looked at those measurements realizes that there's a benefit in renin-angiotensin inhibitor usage. Now, if you look at those persons who have CKD, who have G1 to G4 with albuminuria, it's the same thing, although you could argue in terms of those persons who may have A1, Dr. Christopher went through that. Those are the persons who have CKD, but the albumin creatinine ratio is less than 30 in terms of whether you should use renin-angiotensin system inhibitor. But once they start to get to greater than 30, certainly the recommendation is there to use renin-angiotensin inhibitors. Also, this is just the slide, as I was mentioning, with diabetic nephropathies, clinical syndrome. We know about persistent albuminuria. We know about progressive decline in GFR, but what is getting new is the elevated arterial blood pressure that is being added. So in terms of the patient with diabetes now and CKD, it's the same kind of strategy, treat the person with the aim of reducing their cardiovascular. So in all of the patients with diabetes and kidney disease, glycemic control is important, blood pressure control is important, lipid management is also important. And then most patients, you need to initiate the use of SGLT2 inhibitors and consider renin-angiotensin system inhibitors, and then antiplatelet therapy, whether for primary or secondary prevention of cardiovascular disease. Now, lifestyle. This is the slide that I was referring to earlier on. You should refer the patient to the dietitian, especially those who have knowledge of CKD. Because, for example, while we recommend brown rice for a diabetic person, when you have advanced Is there a reason why I was muted?
You were silent for about less than 30 seconds.
Oh, okay, sorry.
You can continue on this slide.
Okay, so for persons who have diabetes without CKD, they usually tell them, you know, brown rice, fibers, and all these things are good for you, so as not to, you know, cause to reduce your cardiovascular disease. But when you have CKD, some of these things have to be reversed. And so it's important that the dietitian also has a good grasp of CKD, and so they can advise the patient appropriately. And this is what I use. I use this plate theory for the patient. Just imagine I divide it into four pies. Half of the pie should be fruits and vegetables, colored, of course. This is your protein, animal or plant. You can decide to go plant, especially if the patient also has hyperuricemia, and then whole grain starch and whole grain starch and vegetable as your source. And if it's a bowl, it's the same thing. And you can use this so as to guide the patient so they can understand what portion, because sometimes they see the nutritionist, when they get back, they're not sure what the plate should look like or how much of this they should eat and how much of that can they consume. What they would complain is that they go to the dietitian and everybody tells them what not to eat, but I want to know what I should eat. So if they have a dietary sheet, you can now supplement what portion should the plate look like. It is important also just to sort of, look at the summary of how we treat this patient with diabetes and CKD. So at the cornerstone is lifestyle therapy, physical activity, nutrition, and weight loss. And then we have first-line therapy with the use of metformin, and the recommendation by KDIGO is use of SGLT2 inhibitors. Obviously, we need to try and avoid when they have reduced GFR or persons who are on dialysis. It really just has to do with the mechanism of action for this drug. And then we should consider adding other drugs, GLP-1 agonists, DPP-4, insulins, SUs, TZDs, and alpha-glucanase inhibitors. Obviously, you need to be guided by the patient's preference, eGFR, cost, in all of these things, and if the patient is on dialysis. Now, what I must say though, if you have a patient that is on metformin, please just make sure that you do their vitamin B12 level at least after 4 years of starting the metformin. So for me, the patients will have come on metformin to me, so I would take the opportunity to check their vitamin B12 level. And also the fact that not all sulfonylureas are the same. So you need to look at sulfonylurea that will reduce HbA1c, does not cause an increase in BMI, and also has renal benefit, especially in our case where, cost still becomes a major issue, especially in the government clinics. Now, what should be the target? So we can debate whether, it should be less than 7 or should be less than 6.5. I tend to go with the American Association of Clinical Endocrinologists, that recommends having HbA1c of less than 6.5, because if you look at the benefit of HbA1c reduction, this sort of follows a U-curve. And the U-curve, right at the bottom of the U-curve, is the HbA1c of around 6.3 or to 6.7. Now, obviously, you do not want to cause hypoglycemia at the risk of trying to reduce GFR. So it's going to be important that you look at several parameters for this patient. So for example, if you're diagnosing somebody as CKD G1, you probably want to, be tighter in terms of your GFR, in terms of your HbA1c. If the person already has macrovascular complication, then you might want to be a little bit lax on the HbA1c. If they have a lot of comorbidities, so they have heart failure, they have dementia, they have ischemic heart disease, then you probably might want to be a bit more lax. Excuse me. on the HbA1c life expectancy. If you don't want to cause any harm, so you want to hypoglycemic awareness. So these are patients who, what I usually say, if you develop diabetic nephropathy, chances are you will have all the other evidence of diabetic microvascular complication. So you need to be careful that they do not have hypoglycemic unawareness, which will predispose them to having more frequent hypoglycemic and could be potentially catastrophic. Resources for the patient, that is very, very important. Hopefully, as we continue to push for the management of persons with diabetes and CKD, the government will hear our cry, and then they can add certain drugs to the formulary, which now becomes more available to the patient. But so individualizing HbA1c range between 6.5 and 8 based on all their comorbidities that is present.
Sorry, Dr. Saiba. Is it possible to start wrapping up? We're running a little bit behind time.
Sure.
Excellent.
So in terms of hyperkalemia, it is important as time goes on, we'll realize that we should not be afraid of hyperkalemia, and we should at least try to manage hyperkalemia clinically rather than not using drugs, because the drugs have benefits that outweighs the risk of hyperkalemia. So advising the patient on review of the causes of AKI, correct volume depletion, reassess other concomitant medication that can cause hyperkalemia is very important. And of course, consider renal artery stenosis if you see a patient with hyperkalemia. And this is just showing you SGLT2 inhibitors and CKD progression. All of them have demonstrated benefit, and so hence why the recommendation by KDIGO. But I must say, though, at the time of this recommendation, the result of DAPA CKD was not out. And this is just a summary of it, which I think you've heard already. But this is where things are going to go. If you look at patients without diabetes, there's also a significant reduction in albumin, in urine albumin creatinine ratio, which favors the use of this drug in non-diabetic persons. Lipids, that's not a recommendation we should treat. There's some controversies as to whether we should do it. Anemia evaluation, which we kind of led to a little bit. Imaging studies, Dr. Chrysostom mentioned the use of contrast. So we need to have a balanced judgment as to what we're going to use in terms of investigating these persons. Other things that we should consider: medication dosage based on GFR, something that a lot of people have fallen short of. Look at the drug, look at the dosing based on the GFR. Reduce infection and hospitalization, because every infection, every hospitalization causes AKI, and that causes faster progression of CKD. When should you refer? These are some of the things that was spoken about. You should refer them, especially if they have acute urinary sediment. If you're unsure, if they have hereditary kidney disease, consider referring the patient to a specialist. And also, comprehensive care, advise patient, although recommendation says diabetes, in terms of quit smoking, this applies also to those who do not have diabetes. So they need to stop smoking, and tell the patient also to reduce their risk of secondhand smoking. So to summarize, remember, it's a renal continuum. So patient starts off with hyperfiltration. They would not have hypertension, but hypertension would develop as things progresses. Their cardiovascular and renal risk also progresses as time goes on. Your ability to prevent restoration of cardiovascular disease, you only get a chance when they're in the early stages. After that, you can only regress their cardiovascular risk factors. And this is when they develop microalbuminuria, and as they advance, they develop macroalbuminuria. The only thing that's a little bit different is diabetes. When they have kidney disease, the diagnosis of diabetes or the treatment or the requirement for drug actually falls as they move from stage 1 all the way to stage 5. So in a diabetic that's getting frequent hypoglycemic attack, you need to be careful. They might be developing advanced CKD. So This is what we need to do. Find a reversible cause of renal failure, treat it. It's important. Adjust drugs based on their GFR, treat any complication that may occur, refer as early as you can, and try and avoid hypoglycemia, avoid infection, avoid nephrotoxic agent. If there's a renal obstruction, you need to evaluate with an ultrasound, and that obstruction needs to be relieved immediately. We need to slow down the progression. Don't forget to refer them to the dietitian. And don't forget that when you're doing your blood pressure, it needs to be done appropriately. So I end with this. Is albuminuria and CKD a precursor or mark of cardiovascular disease? The answer is definitely yes. I thank you.
Wonderful. Thank you so much, Dr. Soyiba. That was stellar. I mean, a lot of information that's very useful to us. We are running a little bit behind time, so I'm going to ask if you could answer. There are about 4 questions in the question and answer. If you could answer those for us, we're going to move to our sponsor's presentation.
Hi, in case you're just joining, I'm Michael, one of your CVRM medical representative with AstraZeneca, and I just wanted to bring you through the renal endpoints of our DAPA-HF study. This was a study that was focused on patients with heart failure, but we also looked at the renal aspect of things. So as we know that heart failure and chronic kidney disease are very closely interlinked. In 2017, heart failure had a global prevalence of 64 million. Chronic kidney disease was also very prevalent at 843 million. So in fact, more patients are living with chronic kidney disease. Diabetes had a prevalence of 463 million in 2019, and it is slated to even get worse. So the vicious cycle between heart failure and chronic kidney disease, where one causes or worsens the other, all within the sphere of diabetes and hypertension. 24% of patients with type 2 diabetes actually has heart failure as their first complication. And a whopping 58% of patients with type 2 diabetes will develop chronic kidney disease. It was important to set the stage here because now it is that we want to show you the exciting results that you can expect from a product like dapagliflozin. So the DAPA-HF, just to give you a quick rundown of the trial design, included 4,744 patients with heart failure, New York Heart Association, class 2 to 4, for more than 2 months with a left ventricular ejection fraction less than 40%. So the study actually spanned a total of 18.2 months, and as you are seeing, the primary endpoint there was looking at CV death or hospitalizations for heart failure or an urgent heart failure visit. But what we want to focus on is really the secondary endpoint here, which is the time to first occurrence of any of the components of the composite, greater than 50% decline in the eGFR, or reaching end-stage renal disease or renal death. So as we can see here, hospitalizations for heart failure and CV death was reduced by a significant 26%. And in fact, the reduction was actually seen very early, within 3 months. So the curve separated very early and continued to diverge over the span of the study. To look at the renal side of things, the reduction here that was seen was about 25% in the renal composite endpoint of more than 50% sustained decline in the eGFR, end-stage renal disease, or renal death. As you can see from the DAPA-HF study, that it not only helps to lower the risk of your patients in terms of CV death and hospitalizations for heart failure, which patients with chronic kidney disease are prone for, but it also helps to slow the progression. Two major benefits that your patients definitely will be grateful for.
Thank you so much. So we go to session 2 now, and our moderator for session 2 will be Dr. Aldis Buckland. Dr. Buckland, welcome as we hand over to your capable hands. Good afternoon.
Good afternoon. Can you see me?
Yes, you're looking beautiful, and we're hearing you as well.
Thank you. It is such a wonderful day, and I have so enjoyed and learned a lot from the previous presenters on chronic kidney disease. I think amid all of this, I think I would just like to suggest that we look at person's emotional energy, and because that emotional energy, how they feel about themselves, how they feel about the conditions as they work together as a team with us, the doctors and the other healthcare workers, so that they feel energized to have hope that things will actually improve, and that they can they have agency, they have the ability to make a difference, because they matter, their family matters just as much as we matter. So as a healthcare team, we embrace the entire family that the patient is coming from, because that is the patient's support network. So thank you so much. And this is session 2. Welcome, everyone. One moment. I have to do some housekeeping. All right, so our first presenter is Dr. Basil Babalal, and he's going to be speaking on hematuria, proteinuria in early stages of chronic kidney disease, management of early signs associated with chronic kidney disease. Well, who is Dr. Babalal? I have met him before. He is a very dynamic person. He's a nephrologist, and he is a graduate of the University of the West Indies, Mona. He did additional nephrology training at Unidos in Panama, and he has been practicing at the Kingston Public Hospital for 25 years. He also works part-time at Liam Dialysis in Portmore Pines, and he hails from St. Mary and is passionate about his job. Because he's passionate about his job, he's going to bring the same energy to share about the topic in discussion now, hematuria, proteinuria in early stages of chronic kidney disease and management of early signs associated with chronic kidney disease. Dr. Babalal, the floor is yours. Welcome.
Dr. Babalal, hi, good afternoon. Not sure if you're hearing us.
Good afternoon.
Afternoon, seeing your presentation, seeing you now. Enjoy.
Okay. Good afternoon, everyone. As I say, my topic is hematuria, proteinuria, and early management of CKD. Now, as a cricketer, I was a bowler, and I used to bat at number 11. So usually I'm not needed and to bat. Is it? So most of the things that will be discussed was already discussed by Dr. Shoibo and Dr. Chrysostom. The only thing that's different is the hematuria aspect, which is not much because most of the hematuria that have, in glomerular disease, usually most of the hematuria that occurs in kidney disease is usually managed by the is non-nephrological. What I'll be discussing, to start with, I'll be starting with proteinuria. Normally, proteinuria is the building block in the body. It's essential for growth and repair. Basically, it's usually present in the blood and it's filtered by the kidney, but only a tiny amount is really filtered in the urine, comes out in the urine, because there's barrier in the glomerulus that prevents protein from exiting the body. Now, normal protein excretion is less than about 150 milligram per day. The majority of it is from the tubular cells, 50%, which is from Tom Ashwell, which is called Tom Ashwell protein. This is usually not seen on normal dipstick. Only the albumin excretion is really seen when you measure it in the urine, less than 20 milligram. Tom Ashwell protein is from tubular cells. Normally, it's produced by the tubular cells in the distal tube of Henle and the distal tubules, but it's not usually picked up on dipstick. So the types of proteinuria we normally refer to, there are 3 types, namely abnormal proteinuria. There's the glomerular proteinuria, tubular, and overflow proteinuria. Glomerular proteinuria is the one that you normally see and the one that nephrologists are interested, but all 3 are important. The glomerular proteinuria, as I say, is the albumin are filtered, and that is the one that is picked up on the dipstick. So the glomerular, when there's an increase in protein in the urine from the glomerula, it's usually a signal that there's damage to the glomerulus. Normally, the glomerulus microscopically has 3 layers, which is the endothelial layers and the basement membrane and the podocytes, the epithelial layer. So whenever there's disruption in this barrier, then you have an increased filtration in the urine, and so it overwhelms the tubular absorption, so it increases. So that's how glomerular proteinuria presents. Now, tubular proteinuria is usually damage to the renal tubular interstitium, and usually this increased production in the tubular interstitium, and also they have failure to reabsorb the filtered protein. The thing about tubular proteinuria is that, as I said, it's not usually picked up on normal dipstick, because what the dipstick measure is really albumin. And you have the overflow proteinuria. This is usually due to an increased production when you have increased production of certain protein. So you have increased filtration of these protein through the glomerulus. So things like heme and myoglobin and light chains. Whenever light chain protein, especially in multiple myeloma, you have an increase in protein in the urine. Again, these are not usually picked up with normal dipstick when they occur. So these slides basically already discussed by the previous presenters. Why are we interested in proteinuria in the urine? As I say, it's a marker for progression of chronic kidney disease, and it's also a marker for cardiovascular disease. As I say, it's the early marker. It's one of the earliest marker, as you see in the slide presented earlier, where in the orange levels, the GFR might not have changed, but yet still there's proteinuria. So that's why proteinuria is important. In terms of presentation of these patients, a lot of them are asymptomatic. So usually they might be just come for a routine checkup and they're picked up at the GP office. So it's important that one screen every person that comes in, that walks into the office with a urine dipstick, because a lot of them are asymptomatic. Sometimes they might have edema, and the edema might be periorbital or in the ankle initially, but proteinuria might get so bad that they present with generalized swelling and therefore weight gain. In terms of, because it's a marker of kidney disease, proteinuria, patients might develop hypertension with the proteinuria. So it's essential that everyone that who presents with hypertension for the first time is screened fully for kidney disease. And also they might get loss of appetite later on in their disease, because as they get more edematous, they might have problem with dyspepsia. So in patients with proteinuria, they may also have hematuria, and hematuria due to parenchymal disease may either be glomerular or non-glomerular. So it's important to classify these patients. Now, hematuria is usually it presents because there's a disruption in the endothelium of the glomerulus. So, and they might be further classified as microscopic or macroscopic. Now, both microscopic and macroscopic hematuria can be from glomerular damage. In terms of microscopic hematuria, again, they might not have any symptoms, and it's just when you dipstick the urine, you might see a change in color of the dipstick. And also, if you're doing a proper urinalysis where you send it to the lab, then they'll examine it microscopically. And once they see more than 3 RBC per eye power field, then it's regarded as microscopic. Macroscopic, they would be symptomatic and they present with red urine. how do these patients present that have hematuria? They might present with pain. So they might have some patients with, they might have colicky pain, or they might have dysuria. So especially if the hematuria is due to an infection, then they might have dysuria. If it's low down, if it's higher up, they might have line pain. They have like stones or malignancy, they might develop colicky pain. Or they might present with symptoms of vasculitis. Because patients with vasculitic disease, they do tend to have glomerular damage causing hematuria. In terms of patient presented with hematuria, you have to look at their risk factors. Smoking, the risk factors for malignancy. Smoking is really the #1 risk factors, and immunosuppression is also a risk factor for malignancy. I remember a patient once where they present with nephrotic range protein, but they also had microscopic hematuria. They were biopsied, and it turned out that they had FSGS. And later on, we treated them with steroids. They developed diabetes, steroid-induced diabetes, and then later on, we had to switch to mycophenolate. But they resolved their proteinuria resolved, and then they still had the hematuria. And what we found out later when we did the ultrasound, they had a bladder cancer. So you see, when you do start immunosuppression, even though you might have a diagnosis before, you have to investigate them. The other cause, you have to look at family history. In our population, sickle cell disease and APKD are most common. So they might present with painful hematuria. They can also have exercise-induced hematuria. And also, if patients are on anticoagulants, they might develop hematuria. The thing about anticoagulants, if they do have hematuria, you might still have to investigate them unless they present with generalized bleeding. So you have to look at that also. So how do you evaluate this patient? Now you inspect. The first thing is to inspect the urine. In hematuria, the urine looks red, almost, or it can be brownish, reddish brown, orangish like. So when you see that, it's most likely due to hematuria. Things that they can discolor also, it would be like bilirubin. It would look brownish, so you have to be careful. So you might have to, as I said, when you dipstick the urine, you might have to look at the bilirubin when you see a urine like that. The red urine, there are other causes for red urine. So yeah, you might have to ask about beet. There's some persons who eat beet might have red urine. Drugs such as rifampicin might cause red urine also. Just recently, a diabetic who had increased blood and creatinine was referred to me with red urine. And what I found out, he was eating beet. Because when I dipstick the urine, there was nothing in there, no blood. When you inspect the urine, it might also look white. And this can be from pyuria, or it can be from chylous, from fat, or it can be from drugs such as propofol. The other thing when you evaluate in these patients complete might look purple. I'm sure persons, patients who are catheter dependent, and this is usually due to bacteria, and then the bag look purple on the urine, and they call this the purple bag syndrome. And it can also look black. Now, heme and myoglobulin can also present with the red urine, but it can also look black also. And then when you inspect the urine also, you might get frothy urine. Further evaluation of the urine for both protein and hematuria, you can get your dipstick. The thing about dipstick is that it's cheap. So everybody, as I said, coming through your door should have a dipstick, right? It's a screen, and it can tell multiple things other than blood and urine. It can tell you about the glucose, it can tell you about nitrites, it can tell you about leukocytes, right? So you should really evaluate every patient. And in terms of further evaluation, whenever you see hematuria, then the next step is to do microscopy. So, and once you have more than 3 RBCs per eye power field, then you can you deduce that the patient has hematuria. In terms of to differentiate if this is glomerular hematuria or non-glomerular hematuria, then what we use is if they have significant proteinuria, so greater than 1 gram, you most likely have a glomerular hematuria. And then in dysmorphic cells, normally when the red blood cells are coming through the glomerulus, then they might change in size and shape. And once you have greater than 25% per eye power field, then there is a 96% specificity that you have a glomerular hematuria. But you don't normally see this, and it's only present in the sensitivity is about 20%. So it has good sensitivity. It also has good, very predictive value. But the sensitivity is usually low. And then the other thing you look for to tell if this is a glomerular hematuria is that you might get red blood cell cast. So normally leukocytes, that should be leukocytes. You look also for leukocytes in the urine. So once you see more than 6, once you have less than normally leukocyte is seen in the urine, and whenever it also picked up on dipstick, but microscopically it's usually less than 6 per eye power field. So once it's abnormal, 6 or more in your eye power field, then we normally say it's due to inflammation. Now, leukocytes tend to be less depending on where you collect the sample. So in the bladder, it would be less versus when you collect it from the urethra. So MSU per se. So also in females, there might be vaginal contamination. So you get more leukocytes in those patients. When you evaluating also, you look also for casts. Now, casts are cylindrical structure that are formed in the lumen from organic matrix. The major component of the matrix is sperm-ashfall glycoprotein. Normally, you have physiologic cause, and you get like iodine cause, and you can get granular cause. Now, the iodine cause is usually made up of transparent proteins, and the granular cause is usually from dead cells. So you can see characteristically, whenever patient have tubular necrosis, they might get a muddy brown granular cast, which is like a dead from the epithelium. So those forms are granular cast. But the pathologic cast you really look for again is red cell cast, and this is indicative of glomerular damage. In terms of other evaluation, you can also look for crystals, calcium crystals, and uric acid crystals. So once you see protein in the urine, you're going to have to quantify it, which was already discussed. So you have the 24-hour urine collection. This is the gold standard for collect, but there, as they pointed out, there are collection problem. What I usually tell patients is to start at 6 o'clock in the morning. They discard the urine prior to when they wake up at 6, and then they start afresh. So they start everything they pass from then until the next morning, 6 o'clock is to be collected. It's supposed to be kept in the refrigerator, but again, because some of them have, because of convenience, some of them cannot, but it should be brought to the lab immediately. What I do also is to do a total creatinine excretion, because that will give you an idea if the sample was collected properly or not. So normally it varies between male and female. I think it's a little lower in female and a little higher in male. So but usually the lab has the standardization, and you can look if it was collected properly. Once that is in the normal range, then you know it was a proper collection. The albumin creatinine ratio, as I said, it's really the gold standard, but it's only measuring albumin creatinine. So the thing about it's usually assuming that you're passing 1 gram of creatinine per day. Now, things, as they say, creatinine is affected by other physiologic based on physiology. It can be affected by your muscle mass, can be affected by your diet. So usually, and again, it's affected. Protein, the excretion is affected by your activity and being orthostatic or not. So usually the gold standard, as they say, is to get an early morning collection as soon as you wake up. The albumin creatinine ratio, sorry, it should be protein creatinine ratio. Again, that's if you suspect other type of damage, protein losses, right? So like if you have overflow or tubular protein, then protein creatinine ratio is actually a better measurement. But routinely, like as I said, for like diabetic, you expect glomerular damage, so you use the albumin creatinine ratio. So these are the terminology you will see. Albumin, which was formerly microalbuminuria, and that's 30 milligram per to 300 milligram per gram. You can get overt proteinuria, which is greater than 300 milligram. You get nephrotic range, nephrotic syndrome, which is we get proteinuria greater than 3 grams of protein, 3 gram per gram of protein, and you get hypoalbuminemia and hyperlipidemia. And nephrotic syndrome, which you get proteinuria, but it's non-nephrotic range. Well, and you can get hematuria, which is either microscopic or macroscopic, and also hypertension and azotemia. The other terminology is isolated proteinuria. Now, this term is really a term that is usually a benign proteinuria. So if you don't have any systemic disease, and this is usually after evaluation, which you think is a benign proteinuria. So if you get a proteinuria, which is less than 1 gram, with no hypertension, diabetes, or vascular disease, then, and with normal bone and creatinine, then we regard it as isolated proteinuria, but the patient still require follow-up by a nephrologist from time to time to check if it's worsening. And then you have transient proteinuria, which is the patient might have like exercise and they have increased proteinuria, and they might also have hematuria from exercise-induced proteinuria. But this is usually transient. They might have like a fever, infection, might be orthostatic too, but it's usually transient and usually doesn't require investigation. So how do you manage these patients? Most of the management was discussed prior to this by Dr. Shoibo and Dr. Chrysostom. But the principles is you look for an etiology same way, you look at risk of progression, and you assess cardiovascular risk. So nothing new really. In terms of etiology, when you have renal parenchymal causes, as I say, you really want to know if it's glomerular versus non-glomerular, right? Now, for the glomerular part, you might, as I said, this is hematuria associated with proteinuria, or they might have significant proteinuria, or they might have CAS in their microscopy. So these are the patients we really need, the nephrologists really need to evaluate fully, and they might end up with kidney biopsies if we don't find a cause. They really and surely they need to be fully investigated. These are the patients that need to be investigated fully. In terms of your management, as I say, it depends on your underlying disease. So as the risk assessment. So these are the when you risk assess them, these are the patients who usually need to be referred for nephrology consultation. So once you don't know the underlying disease, you have to refer. If they have decreased renal function, if they have significant proteinuria, so the degree of proteinuria. And again, if they have concurrent hematuria, they need to be referred. If their blood pressures are not controlled and if their glucose are not controlled, they all need to be referred to the nephrologist. This was already discussed again, the blood pressure control, the goal. They are more aggressive depending on the degree of proteinuria. So you might aim for 120, 80, 75 in some patient. And again, in the sprint trial, you might even want to go lower as long as they have cardiovascular benefits. So it depends on your patient. As long as they can tolerate the reduced blood pressure without a problem, then you can go as low as 120, 75. In terms of your glucose control, you have to monitor them. You look at the HbA1c. Again, in patients who have renal disease, they might be anemic, so you have to take that into consideration when you're interpreting the A1C. You have other markers such as fructosamine and glycated albumin. So the thing about those though, once you have proteinuria, they are also affected because their half-life changes. So they're not really good monitors if you have proteinuria. So a lot of the times, especially in the later stage, we have to stick the GMR monitor at home. In terms of your choice of medication, this was already alluded to before also, that the SGLT2 inhibitors have added effects of reducing intraglomerular pressures and also decreasing proteinuria, and also the cardiovascular benefits of using them also. In terms of your reducing proteinuria, again, this was discussed, ACE inhibitors and ARBs. Just to say that there are some patients who might, I know it's controversial, but there are some patients who might require both in terms of trying to reduce proteinuria. You have to approach these patients with caution. So the main problem with ACE is the hyperkalemia, as discussed before. And also they might be at risk of develop acute kidney injury. So you have to monitor the GFR, make sure there's no worsening over 30%. Once you see that, you have to back off. Also, if you have hyperkalemia, you can use diuretics. And patients who have proteinuria, a lot of the times, as you know, the albumin is responsible for maintaining your oncotic pressure. A lot of times they might actually have some fluid overload. So you can use diuretics in these patients. Now, if potassium, the diuretic of choice would be your potassium sparing diuretic, aldosterone, spironolactone. These also have added benefit in decreasing proteinuria. But if your potassium is a problem, you might have to use loop diuretics. Again, the others, low sodium diet, that was discussed. Don't need to go into that. Protein diet. Now, whenever you see a patient and they're having protein in the urine, their response is always, so if I stop eating protein, will the protein in the kidney, in the urine stop? So they always want to know about diet. Now, what we do is, as I say, is avoid the high protein diet. But as already discussed, you use probably about 1 gram to 1.2 in the early stage of kidney disease, so normal protein. The problem of losing low protein, you might put them at risk of malnourishment. Because as you know, with kidney disease, there are lots of restrictions, and when they go to the dietitian, they always say, boy, the dietitian tell me what not to eat, but they don't tell me what to eat, right? And then they say they don't have anything to eat. And then also to reduce the cardiovascular. Dr. Shoaib also discuss those lifestyle changes, use of statins, smoking, exercise, and diet, and weight reduction, of course. So the takeaway is that screening is very important in your high-risk group, your diabetic, hypertension, and obese patient. You should always aim to do a urine dipstick in the office. In terms of albuminuria, it is not a disease. It's just a marker, and let's say it's a risk for cardiovascular mortality. So they need to be evaluated and the risk adjusted accordingly. And hematuria with no significant proteinuria is usually urological in origin. So this patient could be referred to urology. Well, thank you for listening, for your patience. And I do thank you for referring the patients. Thank you for your patience. Questions? As I said, most of my topic was already discussed, so since we are running behind time, I didn't delve into many of the stuff I had planned.
Dr. Babalal, you did a good batting. Excellent. Excellent.
I have no bilingual.
You allowed your team to score many goals. Excellent. All right, so it's turning over now to question and answer. So Sam, over to you, and then you can field them to Dr. Babalal. Thank you.
Dr. Babalal, thank you for your presentation. Actually, only seen questions just now for Dr. Saibo, and he has been typing some of those questions in there. I believe it's because of how relaxed and how well said your presentation was. Definitely getting a lot of commendations in the chat. So, ladies and gentlemen, we'll give another minute or two to type some questions. Yep, definitely, Dr. Thompson, Cicely Thompson, Dr. Okay, Doc, hopefully you're hearing me now. So I do have a question here for you. First, there was some commendations. Question here. Could you please explain hemolytic uremic syndrome? Dr. Babalal, can you hear me?
Me?
Yes. Could you please explain hemolytic
How do you come out
uremic
of the
syndrome?
screen? How do you come out of the screen again?
That's a good
Share
question.
screen.
You have to minimize, but I've stopped your share screen. So you can just go back to the Zoom application.
Okay, well, hemolytic uremic syndrome is usually a post-infectious problems that occur in the younger age group. It's usually associated with E. coli. So the thing about it is that they get bacteremia and they get hemolysis and they get fragmentation, and this comes out in the urine as heme actually. So they get blood in the urine, so they get very red urine. So they get an acute kidney injury from that from the infection and the hemolysis. It's usually seen in the younger age group.
Okay, thank you so much. So there are no further questions. Okay, one more here from Dr. William Green. How much water should healthy persons drink? How much water should persons at various stages of CKD drink? So that's for you, Dr. Babalal, again. So the first part of the question, how much water should healthy persons be drinking? And the second question is, how much water should persons at the various stages of CKD be drinking?
It depends. So it's always a question how much water you should drink. It all depends on what work you do. So if you work in the sun and you're sweating and so, you're going to require more water. Now, in terms of a normal individual, we normally say 6 glasses, but again, as I said, it varies depending on the work you're doing. So you should drink and watch what your urine, what your urine looks like. So if it looks yellow, then you know you're not drinking enough water. Of course, there are other causes for yellow urine. So like if they're taking vitamins, you have to bear that in mind. So the other thing is once you start having chronic kidney disease, I usually tell them to drink as much water as possible still until they notice that their foot is not getting swollen. And again, that depends on if they have cardiovascular issues. Again, so you have to weigh between too much water on the heart and the kidneys. But in the later stage, it depends again on their output, right? So you don't want to send them into fluid overload. So it depends on their output.
Thank you so much, Dr. Sayiba. I think you have your hand raised.
Yes, thank you. I think there's a question by Dr. Ricketts Rooms that Dr. Babalal probably needs to address. And that is asking about hematuria on dipstick. How many microscopic would you need to confirm diagnosis of microscopic hematuria? Is it a single analysis or say 2 or 3 samples with all 3 RBCs per high power field?
So yes, so you're talking about persistent again or transient, right? So sometimes again, you might have hematuria, which is not significant. So, so like again, if you're exercising, you might get hematuria, which is transient. So yeah, on one occasion, really, you don't really need to investigate them. But if you think it's significant microscopically, right? Then you investigate it. Macroscopic hematuria also may be transient. So both is a matter of if you investigate them initially, or you might do some testing initially, but you wouldn't fully investigate them sometimes, depending on the age group. So The threshold for investigating some of them is especially if they are over 40 and if they have risk like prostate disease or cancer. It can be transient also.
Okay, thank you so much. Unfortunately, we don't have much more time left. Dr. Buckland, I'm gonna hand over to you. Thank you so much, Dr. Babalal.
Thank you very much, Dr. Babalal. And it's been very interesting. At this present time, I'll ask AstraZeneca to bring this product spotlight on your important product. Thank you very much,
Thank you so much.
AstraZeneca. Your turn.
We're actually going to have some AstraZeneca product highlights now, as Dr. Buckland said. It's going to take about 20-25 minutes, a number of videos. And we thank AstraZeneca, our sole sponsor of this wonderful, necessary, and timely presentation and conference on nephrology. So, ladies and gentlemen, I'm going to now play those before we hand over to Dr. Buckland again to introduce our final speaker. So, over to AstraZeneca.
Hello, my name is Kian Hutchinson.
And I'm Michael Miller.
And we're both cardiovascular representatives with AstraZeneca.
And it's our pleasure to be joining you this year at the AGPJ Nephrology Conference. We're here to just tell you a little bit about Crestor, a product that you have come to know and love, and one that helps you to effectively control your patient's lipids and reduce their cardiovascular risk. The Kidney Disease Improving Global Outcome KDIGO guidelines actually highlight lipid management as one of the cornerstones in effectively managing your patient's cardiovascular risk, especially patients with chronic kidney disease. The European Society of Cardiology and the European Atherosclerotic Society joint 2019 guidelines have ushered in a new era of LDL-C reductions. As you can see, they are now aiming for even more intensive reductions in the LDL-Cs. For patients, or secondary prevention patients rather, so these are very high risk patients, the LDL-C goal really should be less than 1.4. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, their goal should be less than 1, and we now have therapies like the PCSK9 inhibitors which can be added on top of therapy to help patients to reach these even more stringent goals. For patients at high risk, so these may be primary prevention patients, the baseline reduction or the reductions from baseline should be to less than 1.8 or by 50% reduction. The evidence. So here we have the evidence from the STELLAR study. And this study actually looked at the comparison of Crestor versus other statins in terms of the LDL-C reductions. As you can see, a dose of 10 milligrams of Crestor is able to reduce patients' LDL-C by 45%, and that is actually more potent than 10 or 20 milligrams of atorvastatin. If we go to a dose of 20 milligrams of Crestor, we see that it reduces the LDL-C by 52.4%, and that's approximately equipotent to a dose of 80 milligrams of atorvastatin. Jupiter trial. The Jupiter trial was that study that looked at Crestor's effect in patients with primary prevention. At the time, patients who were enrolled in this study would have actually had low to normal LDL-C levels, but they would have had an increased risk that was categorized by an elevated CRP level. The main endpoint of the study really was to determine if long-term treatment with rosuvastatin 20 mg reduced the rate of first major cardiovascular event as compared with placebo. And at this point, I'm going to ask Kia now to guide you through the outcome of this study.
As is known by now, the primary endpoint of the Jupiter study was met. There was a 44% relative risk reduction. What I'd like to dig down a bit deeper in is the subgroup of patients with chronic kidney disease, who I think most relate to the conference today. It's good to see that regardless of eGFR, be it less than 60 or 60 and above, and for each individual component of the primary endpoint, all saw a significant risk reduction. Of course, when we're looking at renal patients, it's important to see if what we are starting them on will impact their renal function. And here is the evidence that Crestor does not. Across serum creatinine, eGFR, there was no significant change in renal function markers. Now, for these patients, we want to know, of course, how do we prescribe? So for severe renal impairment, not on dialysis, dosing of Crestor should be started at 5 mg once daily and not exceed 10 mg once daily. Here is the gamut of, again, as Michael had said, the drug that we've all grown to know and love. I mentioned just prior that there's a 5 mg dose for severe renal impairment patients, but here's the rest of the Crestor family, 10, 20, and 40 mg. So you can definitely individualize your patient's treatment. Here's some breaking news. We now have a new presentation, a box of 90s, and in practical terms, that means your patients will now be able to get a 25% discount on Crestor.
If you'd like further information, you can scan the QR codes that are now being shown on your screen. For the heart, that will take you to our page exclusively for healthcare professionals, and for the square in black, that will take you to our prescribing information for further details about Crestor. We thank you for your kind attention, and we certainly hope that you will continue to enjoy the rest of this conference.
We look forward to continuing to partner with you for the best possible outcomes for your patients. Thank you.
Hi, my name is Jose Marroquin. I'm the Medical Science Liaison for Cardiovascular, Renal, and Metabolic Diseases of AstraZeneca for Central America and the Caribbean. And today, I'll be speaking briefly of the results of dapagliflozin in our randomized controlled trials focused on renal outcomes. This is our disclaimer, and as you can see, the use in chronic kidney disease is not an approved indication for dapagliflozin in Jamaica. AstraZeneca does not recommend the use of dapagliflozin in any other way than they describe it in the local prescribing information. So the early identification and intervention in chronic kidney disease slows disease progression, preserves kidney function, and improves patient outcomes. So I'm showing in this slide that the most prevalent chronic kidney disease stage is actually stage 3. And there's a decrease between stage 3 and stage 4 and stage 5. This is mainly because the patients died from cardiovascular disease. So the early identification and intervention in chronic kidney disease is essential to slowing progression of chronic kidney disease and reducing the morbidity and the mortality. And we need to remember that the delaying CKD progression is highly desirable because end-stage kidney disease causes significant adverse outcomes and financial burden to patients, families, and the healthcare system. So the risk of morbidity and mortality rises as this chronic kidney disease progresses. And I'm showing in this slide when the eGFR starts to go down, starts to drop, there's an increased rate in hospitalization, but also in cardiovascular events and death from any cause events. Dapagliflozin is an sodium and glucose cotransporter 2 inhibitor. In physiological conditions, reabsorption of glucose and sodium occurs in the proximal convoluted tubule by the SGLT2 receptor in 90% of the cases, and the SGLT1 reabsorbs 10% of the sodium and glucose in the proximal tubule. So in these physiological conditions, there's no urinary excretion of glucose or sodium. But the dynamics change in type 2 diabetes because patients with type 2 diabetes have an increased number of sodium and glucose cotransporters. So because they are having an increased number of these cotransporters, they will have an increased reabsorption of glucose and sodium. And this will be producing a decreased amount of sodium that is delivered to the macula densa. So this effect, this reduction in the delivery of sodium to the macula densa, will produce a vasodilatation of the afferent arteriole, and we will be seeing the effects of this dilatation as an increase of the glomerular pressure and as an increase of the glomerular filtration rate. So when we use SGLT2 inhibitors in this context, we will be blocking the SGLT2 receptors by 50 or 60%. And when we block the reabsorption of sodium and glucose, we will be delivering more sodium to the macula densa, and this will be producing a vasoconstriction in the afferent arteriole. This vasoconstriction will produce a reduction in glomerular pressure and a reduction in the glomerular filtration rate. But also, we will be producing glucosuria, so we will be losing some calories because this glucose excretion, and this will be producing weight reduction, a reduction in blood pressure, and obviously a reduction in glucose levels. So the key physiological effects of SGLT2 inhibitors, we can split them by two. The effects produced by glycosuria, because we are reducing the hyperglycemia, we are reducing the glucotoxicity, the insulin resistance, but also we are reducing the body weight, and the effects produced by the natriuresis and the osmotic diuresis, when we will see a reduction in the interstitial fluid, a reduction in plasma volume, a reduction in blood pressure, and a reduction in glomerular pressure. So these two effects combined, the glycemic and extraglycemic effects, will produce metabolic, cardiovascular, and renal improvements. So with dapagliflozin, we have different trials, and I'm going to focus on 3 different or specific randomized control trials in patients with type 2 diabetes, with heart failure with reduced ejection fraction, with and without diabetes, and mostly in patients with chronic kidney disease with and without diabetes. So the DECLARE-TIMI was the largest, broadest, and longest SGLT2 inhibitor cardiovascular outcome trial to date. And I want to show you, well, 40% of patients have established cardiovascular disease, and 50% of patients have only multiple risk factors. But in this population with diabetes, we can see that most of the patients have normal or near normal eGFR levels. So only 7% of patients included in this trial have an eGFR of less than 60. And most of the patients included in the trial, they have normal levels of albuminuria. Only 7% of those patients have more than 300 USCR in when we included in this trial. So this population with normal or near normal kidney function, dapagliflozin demonstrated a reduction in cardiovascular death or hospitalization for heart failure. But also, we demonstrated an 47% relative risk reduction in eGFR decrease and stage kidney disease or renal death. So we are speaking about kidney progression in this outcome. And when we focused only on the deterioration of the eGFR, dapagliflozin demonstrated a 46% relative risk reduction in eGFR decrease of 40% or more than 40% to less than 60 of eGFR. Dapagliflozin also demonstrated to have some effects in albuminuria. In this trial, dapagliflozin produced a 21 relative risk reduction deterioration from more normal to micro or macroalbuminuria, but also led to greater regression of macroalbuminuria. And this effect was consistent across the eGFR and USCR subgroups, as you can see in this slide. So dapagliflozin, it doesn't matter if the patient have more than 90 of eGFR or less than 60, the effects are positive. And this is similar in taking into account the USCR levels. So if the patient have less than 30 or more than 300, the effects with dapagliflozin over albuminuria are positive. So the DAPA-HF trial was a trial made in patients with heart failure with reduced ejection fraction with and without diabetes. This is the primary objective, but I just want to show that we have also as a secondary outcome a renal objective. And these are the results of this trial. Again, dapagliflozin in this trial that included 50% of patients without diabetes demonstrated a 26% relative risk reduction in cardiovascular death, hospitalization for heart failure, or urgent visit for hospitalization for heart failure. We produced good, 18% relative risk reduction in CV death, 30% reduction in hospitalization for heart failure, but also some improvements in quality of life in our patient. Dapagliflozin also demonstrated a 29% relative risk reduction in this kidney objective outcome and a 17% reduction in all-cause mortality. DAPA-CKD was the first and only SGLT2 inhibitor kidney outcomes trial in patients with chronic kidney disease with and without diabetes. So in this trial, we included 67% of patients with type 2 diabetes and 32% of patients without diabetes. And the eGFR levels, you can read it at the bottom of this slide. And I just want to show you that most of the patients were in a stage 3 or stage 4 of eGFR. And related to USCR levels, you can see that most of the patients included in this trial have more than 300 of USCR baseline category. In this high-risk chronic kidney disease population, dapagliflozin demonstrated a 39% relative risk reduction in the composite of 50% or more of eGFR decline and stage kidney disease, kidney or cardiovascular death. But when we take away CV death of this outcome, we call it renal specific composite outcome, you can see that dapagliflozin produced a 44% relative risk reduction. And at least in my knowledge, DAPA-CKD is the only trial that demonstrated a reduction in all-cause mortality in patients with chronic kidney disease. So we produced a 31% relative risk reduction in this in all-cause mortality in these high-risk population patients with chronic kidney disease. As an exploratory composite outcome, dapagliflozin produced a 34% relative risk reduction in chronic dialysis kidney transplantation, or renal death. Related to safety profile, you can see that in the different trials, dapagliflozin demonstrated a good safety profile compared to placebo. We don't see that major hypoglycemia or diabetic ketoacidosis were observed in patients without type 2 diabetes in DAPA-CKD or DAPA-HF trial. But you can see that the numbers of the results produced with dapagliflozin are pretty similar to those produced in the groups in placebo. So the results of dapagliflozin trials and other trials with SGLT2 inhibitors made some changes in the current treatment guidelines. So the KDIGO guideline now includes SGLT2 inhibitors as they recommend SGLT2 inhibitors as a first step approach in patients with diabetes, combining it with metformin. And they recommend that we can still use SGLT2 inhibitors in patients with eGFR of more than 30. The European Society of Cardiology and European Association for the Study of Diabetes, they recommend SGLT2 inhibitors or GLP-1 receptor agonists for patients with type 2 diabetes at high or very high cardiovascular risk as first-line therapy in drug-naive patients. So in those patients with type 2 diabetes, drug-naive, with very high risk, they recommend actually before metformin the use of SGLT2 inhibitors or GLP-1 receptor agonists. But if the patient is already on metformin, they recommend to add SGLT2 inhibitor or GLP-1 receptor agonist with proven cardiovascular benefits. The ADA guidelines, they also recommend the use of SGLT2 inhibitor or GLP-1 receptor agonist for patients with type 2 diabetes and the following comorbidities: atherosclerotic cardiovascular disease, heart failure, of chronic kidney disease, and this is independent of baseline HbA1c levels. So in patients with atherosclerotic cardiovascular disease, they recommend they use GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit, just like dapagliflozin, as I showed you before. And in the case in patients with diabetes and heart failure, they recommend to add SGLT2 inhibitor with proven evidence in this population, like dapagliflozin. And in patients with chronic kidney disease, they also recommend the use of SGLT2 inhibitors with primary evidence of reducing CKD progression, just like dapagliflozin demonstrated on the DAPA-CKD trial, or SGLT2 inhibitors with evidence of reducing CKD progression of CVOTs, like the DECLARE trial. But also the primary care Diabetes European Association, they recommend the use of with SGLT2 inhibitors or GLP-1 receptor agonist as an add-on to metformin as first-line therapy. In patients also with heart failure, they recommend to add SGLT2 inhibitor, and patients with chronic kidney disease, they recommend to add SGLT2 inhibitor also. And important to say is that WHO last year, they updated the list of essential medicines, and they included for treating patients with type 2 diabetes, the SGLT2 inhibitors as an essential medicine to treat our patients with diabetes. This is the summary of the presentation. Just like to show you that dapagliflozin in the DECLARE trial, the DAPA-HF trial, and DAPA-CKD trial demonstrated good effects on the primary and key secondary outcomes from the renal and cardiovascular point of view. So I hope that this information is useful for your clinical practice, and thank you for your time.
Thank you very much, AstraZeneca.
Hello again. As we draw to the end of this exciting conference, it is my hope that the information shared today would be both beneficial and impactful. I'd also like to use this opportunity to share with you some information about another medication that AstraZeneca offers to help control your patient's blood pressure. Plendil is effective in reducing the ambulatory blood pressure of your patients over a 24-hour period, both in patients with mild and moderate hypertension. And as you see here, Plendil reduces the blood pressure beautifully. Plendil does this also by offering your patients less or fewer vasodilatory adverse events. And in a head-to-head study that compared felodipine or Plendil versus amlodipine, it was seen that peripheral edema was lower as well as any vasodilatory adverse events. So you're getting good efficacy in terms of blood pressure reduction, but also with fewer adverse events. But it doesn't stop there. Plendil also helps to reduce the cardiovascular outcome of patients. And in fact, it was shown in the HOT study to reduce the risk of major cardiovascular events by 30%. In a subset of diabetic patients, it reduced the risk of major CV events by 51%. So we are seeing three things now: effective blood pressure control, less adverse events, and also very good cardiovascular outcomes. The best part of it is that your patients will be able to afford this medication because Plendil is included as a part of the JADEP program. Both 5 and 10 milligram doses of Plendil are on that program. And to remind you that this program offers these medications for only $40 per month. Plendil can be effectively combined with other antihypertensive agents, including ACE inhibitors, beta blockers, and diuretics. I also just want to thank the AGPJ once again on behalf of AstraZeneca for giving us this opportunity to partner with them in putting on this conference. I also want to thank you, the delegates, for your time and attention.
Thank you very much, AstraZeneca. Well, we've certainly got a lot of runs going on there. And for those who stayed, we can applaud. And because we learned a lot about what AstraZeneca is doing and why they're doing what they're doing. So that was a product spotlight. At this time, we have a very interesting presenter. He comes from a country known as Myanmar, and this is Dr. Cho Ho. Dr. Ho, I had to look up Google to learn how to pronounce your name, so I hope I really got it right. He is presenting on drugs and nephrotoxicity and diet and chronic kidney disease. Dr. Cho Ho is a graduate from the Institute of Medicine, Yangon, Myanmar, where he completed his MBBS degree in 1990. He also achieved a postgraduate diploma in general medicine from the Institute of Medicine 2, also in Yangon, Myanmar, in 2000, and a postgraduate Doctor of Medicine, internal medicine degree from the University of the West Indies, Jamaica in 2013. Then he joined intensive clinical fellowship training at the University of the West Indies, Jamaica, and peritoneal dialysis and renal transplant training at the Hospital Civil de Guadalajara, Mexico, from 2013 to 2015. He achieved the fellowship in clinical nephrology in 2015. In 2018, a fellowship of the American College of Physicians. Dr. Ho has been practicing in the Department of Medicine, University Hospital of the West Indies, Jamaica, since 2008. He practices nephrology. This is really his focus, particularly in acute kidney injury. He is a major contributor for publications related to acute kidney injury in Jamaica and the Caribbean. Now, Dr. Ho, you're to present on drugs and nephrotoxicity, diet, and chronic kidney disease. And as you do so, I want you to remember, all of us to remember, that in the event, as we go through on climate change and health, how all of this will impact us. Because we have hyperthermia, we're going to have many different issues that relate to that: dehydration, rhabdomyolysis, exertional heat stroke, myoglobinuria, electrolyte disorders. So Dr. Ho, present to us now on drugs and nephrotoxicity, diet, and chronic kidney disease, bearing in mind also about climate change and health. Thank you very much. Your turn.
Thank you very much, Dr. Buckman, for very nice and comprehensive introduction. I hope everyone had your lunch. And a good thing is hypoglycemia will not cause acute kidney injury, but kidney disease can cause hypoglycemia. So good news is I usually be on time, and so I will try to be finished in time. Bad thing is I have two topics, so you have to listen to separate topics: drugs and nephrotoxicity, and the diet and the chronic kidney disease. So those drugs which can cause kidney damage or injury are known as nephrotoxins. And as we learned before, that abrupt sustained decline in the renal function is called acute kidney injury. So my real topic should be the nephrotoxins and acute kidney injury. Unfortunately, those things, most of or majority of the story started from the clinicians. That is us. Only few people, they got the nephrotoxicity by drugs via the over-the-counter medications. So look at the picture that seems like that we are stabbing at the back of our clients. We don't know which are the nephrotoxic agents. So I give the first poll questions. How many nephrotoxic drugs do you know? That is just teaser to understand, to know whether our clinicians clearly understand what are the nephrotoxins that is available around us. So
we have the poll running. We're going to give them about 10 more seconds. Ooh, they're coming in fast, coming in fast. 5 more seconds, and then I'll show you the results. 4, 3, 2. And these are the results. So 38% say 1 to 3.
That's no wonder that our nephrologists are also lazy. So whenever we get a consult, we give very brief input. That is to avoid nephrotoxic agents. And most of our colleagues' understanding is, oh, I'm not giving any nephrotoxic agents. My patient not getting any NSAIDs. And the patient is not on gentamicin, that's it. And we have to explain nicely that to avoid nephrotoxic agent is not the equal to avoid the and just only NSAID and aminoglycosides. All right. So drug-induced nephrotoxicity depends on the three different factors. Of course, drug itself and the exposure and the patient factor. Those parenteral medications, they don't pass through the liver like oral medications, and they give the extra work through the kidneys, because only kidney has liver detoxify or remove those exogenous substances. So if we prescribe the intravenous medications for long duration, higher dose, particularly medications like aminoglycoside, platinum, amphotericin, and colistin, they cause direct toxicity to the kidneys, where they are main properties or through their large molecular weights, which can affect those things. Another problem is few people, they have hypersensitivity problem. Their body may produce heptane, proheptans, some allergens, or their immune system may fight back those drugs and part of the drugs. And they think it's an antigen or any other viruses that we all know as a molecular mimicry. And those things will cause an immune reaction, B-cell activation, T-cell activations. And if this occurs inside the kidney, of course, battlefield will suffer. So medication like antibiotics, penicillin, cephalosporin, sulfonamides, and NSAIDs, PPI, very commonly used medication, and aminoglycosides, they can induce an immunologic or allergic reaction to the kidney. If these properties combine together, so medicine like NSAIDs, those radio contrast agent, ACE or ARV, cisplatin, aminoglycoside, if person have immunologic action, allergic reaction to this, they will get the more problem. Some of the medications excreted by urine, and it can form the crystals inside the urine that we call crystal nephropathy. It's blockage of all the tubules. So medications like the methotrexate, acyclovir, endinava, atazanavir, sulfadiazine, vitamin C as well, and or phosphates and triamterene, phosphonate, they can cause crystal nephropathy. And some of those osmotically active drugs, they can accumulate inside the tubular lining epithelium, substance like those HES, all right? So hydroxide starch or any high percentage of glucose, it can cause accumulation inside the renal cells, and it can cause a renal injury. Some of the medications, particularly vancomycin, which form the cast formation and which will block the renal tubules, that is called cast nephropathy. And medications with positive charges, we all know that those glomeruli functioning unit basement membrane outlined by the negative charges. So if we use the medications with positive charges, they will easily go inside the cell, and they can cause the damage inside via direct toxicity or via immunologic pathways. And some of the ARVs, adifovir, pseudofovir, tenofovir, they can directly damage the mitochondria, the lungs of the cells. So there are various mechanisms which can cause renal injury. So when we look at this table, you will see that those are different nephrotoxic agents called the different kinds of the nephropathies. Those beta-lactam antibiotics, NSAIDs, gold, lithium, palmidronate, interferon, they can cause glomerulonephritis. And a lot of medications including commonly used medication like diuretics, allopurinol, antibiotics, PPI, NSAIDs. those can cause acute interstitial nephritis. If you go to long term, it will cause chronic interstitial nephritis. And we think that acetaminophen is quite safe. Yes, safe relatively, but chronic use can cause a chronic interstitial nephritis. Cyclosporin, cisplatin, we know that those are nephrotoxic agents. Main pathway is because of chronic interstitial nephritis. And Chinese herbs, lithium, NSAIDs, they can cause chronic interstitial nephritis. Aminoglycoside, amphotericin, adiphoba, siropoba, cisplatin, contrast agents, foscarnet, so and so, including zoledronic, they can cause direct tubular toxicity, which is very dangerous. It can cause acute tubular necrosis if in the long term, and it may be permanent. And few of those patients who develop irreversible tubular depression, they require dialysis after exposure to these agents. I mentioned that some agents can cause a crystal nephropathy, and renal protective agents like ACE, ARB, they can also alter renal blood flow, and they can also affect the GFR. They can also cause acute kidney injury. And certain medication like clopidogrel, ticlopidine, we use it to prevent the MRI stroke, but they can cause a thrombotic microangiopathy inside the kidney. And statins, DPH, very commonly used medications, haloperidol, and stimulants like cocaine, heroin, they can cause rhabdomyolysis and acute kidney injury. So you will be very reluctant to use medicine if you know that they can affect the kidneys one or any different ways. So no medicine is safe to the kidneys. So you have to judge before you prescribe the medications. Any more? The next compound is the normal saline. Normal saline. The guidelines start to write these things together to avoid nephrotoxins, to avoid normal saline together. So many renal guidelines, they officially using it now. That's a commonest intravenous fluid we used in the past. So we did a study on that, and I was the main correspondent. We have published recently this normal saline and acute kidney injury in hospitalized patients. I'll not go very detailed. You can Google it, but based on this study, there's a population in the admitted patient from 2016 to 2018. The commonest nephrotoxin which caused acute kidney injury in the hospital is the normal saline. Then followed by the PPI and loop diuretics, cephalosporin, so and so. And you will see the aminoglycoside-induced nephropathy is very low, very low. But which are the statistically significant? Normal saline, very significant, and aminoglycoside, very significant. So we must be careful with these compounds and other things as well. So this is poll number 2, second thesis. Which one of the following drugs? Second one, next one. The next one.
I didn't get that one. This is the only other one that I have. This is the wrong time.
Okay.
Should I pull it?
All right, sure. Then it's okay. All right.
Okay. So far they're answering. I did see that
Yes.
a couple of my doctor friends said that they missed the last one. It was very quick. to Dr. Small, Dr. Cargill. I'm hoping you guys are participating in this one.
Sure. Okay, no problem. I will.
Let me give you the result right here.
All right, it's okay. I will give the straightforward answer. All right. All right.
Okay.
Good. So for this particular one, based on the US FDA research study, they found out very shocking outcomes that is only 16.5% of the acute kidney injury were because of known nephrotoxin, and 64.8% was because of the new potential nephrotoxins. So this quite shocking figures, meaning that we have to focus more on these new potential nephrotoxin to prevent the acute kidney injury. And the final factor is the patient's factors. You may argue that many people are taking NSAIDs, they don't get the AKI. And my relative getting aminoglycoside, he or she does not get AKI. Yes, it depends on individual. But each and every exposure is important. What I'm telling you about is the vulnerability, but I did another study to show that exposure is more important than vulnerability. Each exposure must be taken seriously, and that can affect any kind of the, regardless of age, gender, all right? So, but these are common, those patients with comorbidities, elderly age, female, and this Afro-Caribbean descent, they are at higher risk to develop the acute kidney injury. They are known as a vulnerable group. And if they exposed to those known nephrotoxin or potential nephrotoxin, they can get the acute kidney injury. I will stop for first presentation here. Rule number 1 is do no harm. KNOW, no. We must know what are the lesser known nephrotoxins. Okay, so let me proceed to the next. That is very broad one, and diet and CKD. So, we need to learn more about that. Before we talk about diet and CKD, we have to know about diet and kidneys first. So there are two portions. One is diet for the healthy kidney, and another one is a diet for the CKD patients, which is known as a renal diet. Without knowing the diet for the healthy kidneys, we cannot give complete education to our patients, right? So some of the diets are dangerous to the kidneys, which you may not see in the guidelines of CKD management. So that's why I start from the diet for the healthy kidneys. And I myself give a special name for those diets. First, but I spoke about nephrotoxic drugs. Now I will talk about nephrotoxic diet. So if you know the nephrotoxic diet, you can help those normal people from the AKI and those CKD patients as well, because they need to preserve their residual renal function. So the first thing is to cut down the sodium intake, less than 1 teaspoonful a day. Scientifically, less than 2,300 milligrams per day or 90 milliequivalent a day. That is very important because the sodium It's a vasoconstrictor to the renal arterioles. It inhibits nitric oxide synthase. All right, that's why normal saline is nephrotoxic. But more than that, why nephrotoxic? Why normal saline is nephrotoxic? It's more than that, right? Because I did detailed study on that. So need to control the sodium tightly in those everyone. Right? If you don't want to get a kidney problem, you have to tightly control the sodium intake. And need to reduce the red meat, high acidity, highly osmolar. So there are many studies, all right, stating that too much red meat might harm kidneys. And red meat consumption linked to the kidney failure, and many more studies. So we have to avoid eating too much red meat. Then need to cut down the processed foods, because we contain the sodium phosphate additives, which have the negative effect on the kidneys. So examples are those crackers, potato chips, cheese product, deli meats. And we have to slow down with our sugar intake, because sugar is osmotically added substance. And it can cause diabetes, it can cause obesity, all can cause glomerular hyperfiltration. I saw the one question, how glomerular hyperfiltration. It's too much volume pass through the glomerulus. It causes glomerular hypertension, and it's also known as glomerular hypertension, which is a primary cause of damage of those supplying arterioles, which is known as glomerulosclerosis. It's an irreversible problem. So you have to slow down with the sugar and stop soda. It's very important. Many studies done in the past 2 decades, including the school children and women, which show that drinking of soda, either sugary soda or diet soda, more than 600 ml per day, 2 cups of 600 ml per day, will cause declining of GFR more than 3 ml per minute per annum. So better limit your soda intake. Another thing I remember, one of the audience asked about the water intake to the renal patient. Before I forget, I'll tell that in 2014, I telecast at CVM, and I got the same question, and how much water to drink from a renal patient on the television. And my response was, the studies show that if renal patient drinks more than 4 liters per day, a decline in GFR will be more than 5 ml per minute per annum. That's a lot. So the myth was, when a person gets a kidney disease, friends, relatives, they encourage to drink more and more fluid. But please do not advise to drink more than 4 liters per day, any renal patient. And of course, you need to take blood pressure friendly diets. And I wrote an article in 2015 as a moderating editor, and blood pressure and a natural diet, more to learn, in the West Indian Medical Journal. You can Google it. But any of our hypertension control guidelines, HH or JNC or whatever, they recommend DASH diet, dietary approach to stop the hypertension, which is important to prevent the renal issue. And CKD patient also has hypertension and need to know about these things. So food enriched with potassium, calcium, magnesium are good for the hypertension. So they recommend to eat them. Vegetable, fruits, whole grains, fat-free or low-fat dairy products, low-fat dairy products, fish, poultry, beans, nuts, seeds, peas, vegetables, oils. Those are good for the lowering blood pressure or maintaining the blood pressure. So now I go to my assigned area, that is the diet for CKD patients, also known as renal diet. Frequently asked question by our patients, your clients, are what type of food should I follow if I have a kidney disease, or when they have a kidney disease. All right, so so I have seen your poor results. All right, how do we respond to those CKD patients? Dietary restriction for the kidney patient is extremely important because we must slow down the progress of the chronic kidney disease. So once patient reach to the advanced CKD, we need to control tightly. Our previous presenters, they have mentioned that you can be a little lighter in the early stage of CKD, but if it reached to the advanced stage, need to control the protein intake less than 0.8 gram per kg per day. If you don't want them to see on dialysis machine in near future, we have to tightly control that. All right? Because studies show that the tight restriction of protein is quite equal to the offering dialysis, especially in elderly population, and different that group maintain the quality of life. Then choose the whole grain carbohydrates, avoid sugar, honey, any soft drink sodas. Those CKD patients must restrict the sodium, all right? And high sodium will interfere the effect of some medication as well. Medication like ACE or ARB and beta blockers, they are renoprotective, but if patient are taking high salts, their RAS inhibition system is already distorted, already stimulated. So ACE or ARB will not give therapeutic effect. And recommend to take phosphate less than 800 milligram. All right, because CKD, MBD, because severe bone disease, it's because of phosphate, because of PTH, because of calcium metabolism abnormalities. All right? Then we have to control the potassium in the advanced CKD as well. Right? So these are the important things. So I will show the picture of high phosphate diets and which diet are containing less phosphate. All right, so those CKD patients, they should avoid dairy products, nuts, seeds, dry beans, or brand cereal, beverages, including beer or cocoa. Right? If they want to take it, that's things. They must comply with the phosphate binders. They must know when to take the phosphate binders. All right. So during the meal, it's the right instruction. Instead of after meal, some amount of phosphate already absorbed by the stomach or early intestine. Those fresh fruits, fresh vegetables, popcorn, crackers, rice cereal, coffee, tea without milk, they have less phosphate. So they are a bit quite okay to the CKD patient. They also need to be careful with high potassium diet, which is a major cause of death in the CKD population because hyperkalemia causes arrhythmias and cardiac arrest. So they have to limit those high potassium fruits, vegetables, and others. All right. So banana, orange, papaya, mango, avocado, jam, sweet potato, they are high potassium diet. All right. Along with those potato salad, coconut water. You may hear from time to time from your patient. All right. Those things. So which are the low potassium foods? A good thing is those low potassium foods are also low in the phosphate. So they can enjoy the certain amount of the green beans, apple, onion, canned fruit grapes, eggplant, broccoli, watermelon, carrot, pineapple, corn, berries, blueberries, strawberries, cabbage, lettuce, cucumber, popcorn. But everything is limited, okay? So be careful when you educate those patients. So you already answered this, and which is the best approach to control the diets of the CKD patients? Yes, of course, the correct answer is to refer to dietitian. And our guideline also recommend this, right? Because to give the dietary advice to CKD patients, first thing to know is to know about their dietary habit. That is very important, and the most important. We cannot give advice without knowing their dietary habit. Because from time to time, they will ask you, Doc, I have kidney disease. Can I take banana? What is our usual response? Okay, limited. Then exactly that. How about mango? I also like coconut water. All right. So then you said everything limited, and what those persons do that? They will take the one banana, they will take the half of the mango, they will take the half water of the coconut water, and they will reach the hospital with potassium of 7.5 tomorrow. And they will tell that my doctor said to take. That's a problem, okay? So they must go to the dietitian. They must go to the dietitian according to our guideline. And at dietary department, they need to tell about what their usual diet. There are different models. All right, we have the artificial bread, artificial banana, those are models at the dietary department, and they have to show honestly how much they're eating every day, and dietitian will budget. Yes, you have to cut this. You have to reduce this. You should not take this because you're already in the. If you want to take this, forget about this. All right. For example, if you want to take banana, forget about orange. So they need to get proper dietary advice, all right, by the expert, all right, expert. So what is our duty? Usual problem is that so my friends dietitian, they express their frustrations that doctors just refer me for greener diet. I know it's not the right way. They just refer the patient to dietary. Hey, this patient having the CKD, give a dietary advice. That's not the way to refer to the dietitian. Right? When you refer to the dietitian, you need to write an appropriate referral letter, which must include the background medical problems. Patient has hypertension, heart disease, stroke, diabetes, and then they will know which kind of diet they can recommend. And results of the latest UNE, creatinine. If possible, you have to calculate GFR and mention it, calcium, phosphate, albumin, and please also mention when it was done. Recently, it should be recently. And you have to recommend how much calorie to give to your patient. For healthy young female, you can give around the 2,000. Male around 2,500. Diabetes, you would reduce it. Right? But they prefer the range, like the 1,200 to 1,500, 1,500 to 1,800. Right? That's their preference. So better give the preference in range. Right? Then protein as well. You have to weigh the patient, and you have to tell how much protein, 50 grams per day for this patient, and then they will educate based on the patient's dietary habits. Then also recommend how much sodium, all right? 80 milliequivalent per day or 70 milliequivalent per day, depends on patient body weight, usually 1 milliequivalent per kg per day for both sodium and potassium. And recommend amount of fluid per day as well, all right? So if patient had no edema, usually 2 to 2.5 liter is enough, all right? If patient had edema, you can restrict to 1.2 to 1.5 liter. It depends on the patient's urine output. Okay, so my conclusion is patient with CKD needs to comply with a lot of things, every kind of diet, protein, carbohydrate, fat, sodium, chloride, potassium, and phosphate intakes. High sodium, high chloride, red meat, processed food, those harmful diet that I call as nephrotoxic diet. And CKD patients require proper dietary advice by experts. So please guide them to the dietitian. Thank you very much. That's the end of my presentation. I will take the questions. Let me see in the chat.
Thank you, Dr. Ho. Wonderful presentation. First question is, what are red meats to avoid?
All right, those are the beef and mutton, turkey, and some literature, they also put pork.
All right, so that's beef,
mutton, goat,
and pork. All three food groups of rural Jamaica. All right. Yeah. How much soda should I be drinking per day is the next question.
Less than 600 ml per day.
Less than 600 ml a day. Here's another question. Now there's this popularity of these waters that they turned into flavored soda waters. Are those good or should those be avoided?
I don't know that exact chemical inside the flavor, but those kind of, if this is coloring agents, it's not good for both kidneys and bladder, right? Because it associated with urogenital cancers. So I don't think it has direct effect to the kidney function unless patient are hypersensitivity to those flavoring agents.
Thank you so much. Should the potassium restricted in stages 1 to 3? So I'm guessing the question is, should potassium be restricted in stages 1 to 3?
You have to individualize things because with the potassium, I will be very careful because low potassium, low serum potassium is associated with the increased cardiovascular death. That's another major drawback. If serum potassium less than 4 is not good. It increases the risk of MI and stroke. So I'll be very careful. Depends. Go to balance. Try to maintain potassium. Like my hyperkalemic stage in the CKD, that is 5.5 to 5.9. People will think it's too high. No, hyperkalemia is common things, especially they are on ACE or ARB. So if they are on ACE or ARB, we allow up to the 5.9, and we consider it's a mild hyperkalemia. But definitely should not be very too low. If less than 4, need to upgrade a little more. So need to know baseline potassium first before you give your input.
Perfect, thank you. What's your recommendations on IVF for CKD patients? Is this okay?
Yes, you can look at my study paper. It's published in the Journal of Renal Injury Prevention. My study shows that the safe intravenous fluid is 5% dextrose and lactate ringer. So if possible, if patient is not diabetic, you can use a 5% dextrose, which is better than the leterringa. If patient has diabetes, if you need to expand the volume, intravascular volume, please use leterringa.
Gotcha. All right, I think our final question for today's wonderful seminar. At what point should kidney patients be given high protein diet?
At any time, we should not say high protein diet because I just mentioned it's a high protein is low to the kidneys, and so let us say that free protein. All right, that is not limiting the protein. All right, that not limiting the protein is in very early CKD stage 1 and 2. If the GFR is more than 60, you can allow them if they don't have significant proteinuria. The problem is sometimes laymen may think we can reverse the proteinuria by giving protein. That's another issue. All right, should not do that. If you give more protein, proteinuria will be more. So they need to know about that. And another time we lift the restriction is after starting regular frequent dialysis. If we can maintain the target removal, that's called the KTOV, target KTOV with the dialysis, we can allow those patients for the free protein.
All right. Thank you so much, Dr. Ho, and thank you so much, Dr. Buckland, for being our moderator for this session there.
Thank you.
I'll hand over to you, Dr. Buckland.
Sam, one question though, one question. What about eggs?
Which one? Eggs?
Yes.
Oh, they are known as a high phosphate, but not very high like those that I mentioned. These are but a little similar to dairy products, but not real dairy products. So eggs, we should limit to those CKD patients and should recommend to take along with the cevilamar or other phosphate binders. Should take it. All right. And regarding on eggs, some controversy rising in recent years. I hope because that you're asking that question. Previously, we think eggs is not quite friendly for the health, and fewer studies come out that all of a sudden it's quite friendly now. But
they
for
get
renal patients,
2 eggs per week.
Yes, that's quite reasonable because what I read is maximum of 4 eggs per week. So
4 eggs per week.
Okay.
Okay, yes. Thank you. Over to you, Sam.
Thank you. Yes.
Thank you so much, Doc. So the post test is now live, and please visit the chat to do that and complete the post test. And we hand over now to Dr. Anna Brown Morgan to bring the vote of thanks.
Well, today we have certainly experienced a feast of knowledge about chronic kidney disease. There has been a lot of very needed and helpful information shared with us by our excellent presenters today. By name, Dr. Kenil Chrysostom, Dr. Aden Mola Soibo, Dr. Basil Babalal, and Dr. Kayo Ho. We could not have asked for more immersion in what chronic kidney disease is about and what we need to know. Dr. Ho at the end here has taught us a bit about what a mixture of prescribed medications does and how we are responsible for significant nephrotoxicity in our patients. It was amazing to see the amounts of the medications, and of course, knowing how much we polypharmacy with our chronic patients. It was certainly eye-opening. I would also refer to Dr. Soyibo's comparison and say that our presenters today all batted extremely well. And I think we have won our match today. We're really proud to say that thank you to our presenters. And our seasoned moderators, Dr. Peter Swaby and Dr. Albert Buckland, certainly guided us through the conference very expertly and showed great ease and familiarity in their roles as moderators. And we thank them for their competence. And at this time, we'd also like to thank Dr. Donald Gordon for his input. We would like to thank Dr. Arlene Henry Dawkins, who brought blessings to us today in the form of prayer on the conference. We all need these blessings in these times, and we were blessed today because we just had a wonderful, wonderful day. So thank you, Dr. Henry Dawkins. And thanks to our sponsors who themselves shared important and relevant information here on their products and the relevance of their products in the management of chronic kidney disease. So thanks to AstraZeneca. And I'd like to thank the support staff who, without them, this conference could not have taken place. Our thanks go to Mrs. Lynn Hyatt Thompson from the Secretariat, and to Mr. Samuel Heron, who is the IT manager, who of course you hear from as we switch over from one person to the other, and he's been managing our Q&A sessions. And finally, I would like to thank all you participants who have spent your Sunday afternoon with us. It's appreciated. We also noticed that we had some Caribbean participants in our audience from other countries. We thank you so very much for being a part of our conference today. Thank you for attending. And from all of us here to all of our participants, we say thank you very, very much for attending, and we wish you all a wonderful Sunday afternoon.